Hello, hello.
I can hear you.
Perfect.
All the time.
मुझे एडमिट कर लो ना अंदर।
Yeah. Acting very well. It's very weak. I am the
You white, make me host. On,
quiz
make me
master.
host.
Conflict change, no?
Yes. Co-host दिया, उंगली दिया, हाथ पकड़ लिया.
I don't know how I got it. Hello. Is it recording?
मुझे एडमिट कर लेगा ना अंदर।
हाँ, वो चलो. इसमें मेरे से ले रही ना हर्षी.
हाँ. Let's not start framing. Once we let them in, I have to explain them the rules once.
When you tell me to let them in, tell me 2 minutes before that. I have to play an ad.
Before starting?
Yeah.
Okay.
Then I'll start. Then you can start. Then I will start.
So the ad will play. So in that 2 minutes, I have to do nothing.
No, I can still set up. Give me a 2 minute window before you start. Tell me a time when you start.
First, I have to let them in. Then I'll explain them the rules. Let them clear it out. So by 7:15 we should show.
Go to the audience also, na?
Yeah, but I'll tell them, na, camera is supposed to be on. Don't get out of the meeting. Order of.
Which rules बनाने थे? Then you are telling them that.
Can we let them in? We can let them in.
1 second.
Unacademy. Let's crack it.
Hello learners, hope you guys are all keeping safe and healthy.
We are here to help you understand why Unacademy is your go-to platform for next INICT or any medical PG preparation exam.
At Unacademy, we realize the importance of choice, and that is why we want you to choose how, when, where and with whom you study.
For starters, you can choose between live and recorded classes.
If you're interested in a real-time classroom-like experience, join a live batch in which you can interact with your educators, attend structured courses, and solve all your doubts online in real time.
But if recorded classes are your idea of comfort, we hear that too. Soon, you'll be having access to unlimited lecture classes, and you can get them whenever and wherever you wish to watch them.
You can study at your own pace. Play, pause, rewind, forward lectures as per your convenience.
So if you want to taste both, you can go ahead, mix and match both live and recorded classes as you see fit.
Plus, Unacademy is the only online PG learning platform which offers you the chance to see the classes on a bigger screen.
So along with the tablets and mobiles, now we are into the laptops and the desktops.
You can choose your favorite educator for each subject based on your preferences, learning style and requirement.
Personalize your learning journey even further.
And what more you get with Plus subscription is 25,000 plus clinical MCQs with effective, simple understanding.
Plus, you can participate in the country's most toughest and exclusive and extensive test series. You can test your preparations regularly, and you can analyze your performance.
Plus, you have the option to add your notes to your subscription.
So, the choice is yours.
Choose your format.
Choose your device.
Choose your educators.
Choose your notes.
Choose your learning journey.
With Unacademy, choose the best from the best.
MBBS के एग्जाम्स ने निकाल दिया तेल जब रोहित का रट्टू तोता फॉर्मूला हुआ फेल। लेकिन राहुल ने अपनाया था स्मार्ट तरीका, जब चाहा तब इंडिया की टॉप फैकल्टी से सीखा। जब होगी बेस्ट फैकल्टी आपके साथ तो कॉन्सेप्ट क्लियर होंगे हाथ के हाथ, क्योंकि किसी तरह डॉक्टर तो बन जाओगे, लेकिन क्या बेस्ट डॉक्टर कहलाओगे? डिजिनब टॉप डॉग बने वही जिसका गाइड हो सकी।
Unacademy. Let's crack it.
Hello learners, hope you guys are all keeping safe and healthy.
We are here to help you understand why Unacademy is your go-to platform for next INICT or any medical PG preparation exam.
At Unacademy, we realize the importance of choice, and that is why we want you to choose how, when, where and with whom you study.
For starters, you can choose between live and recorded classes.
If you're interested in a real-time classroom-like experience, join a live batch in which you can interact with your educators, attend structured courses, and solve all your doubts online in real time.
But if recorded classes are your idea of comfort, we hear that too. Soon, you'll be having access to unlimited lecture classes, and you can get them whenever and wherever you wish to watch them.
You can study at your own pace. Play, pause, rewind, forward lectures as per your convenience.
So if you want to taste both, you can go ahead, mix and match both live and recorded classes as you see fit.
Plus, Unacademy is the only online PG learning platform which offers you the chance to see the classes on a bigger screen.
So along with the tablets and mobiles, now we are into the laptops and the desktops.
You can choose your favorite educator for each subject based on your preferences, learning style and requirement.
Personalize your learning journey even further.
And what more you get with Plus subscription is 25,000 plus clinical MCQs with effective, simple understanding.
Plus, you can participate in the country's most toughest and exclusive and extensive test series. You can test your preparations regularly and you can analyze your performance.
Plus, you have the option to add your notes to your subscription.
So, the choice is yours.
Choose your format.
Choose your device.
Choose your educators.
Choose your notes.
Choose your learning journey.
With Unacademy, choose the best from the best.
MBBS के एग्जाम्स ने निकाल दिया तेल जब रोहित का रट्टू तोता फॉर्मूला हुआ फेल। लेकिन राहुल ने अपनाया था स्मार्ट तरीका, जब चाहा तब इंडिया की टॉप फैकल्टी से सीखा। जब होगी बेस्ट फैकल्टी आपके साथ तो कॉन्सेप्ट क्लियर होंगे हाथ के हाथ, क्योंकि किसी तरह डॉक्टर तो बन जाओगे, लेकिन क्या बेस्ट डॉक्टर कहलाओगे? डिड यू नो टॉप डॉग बने वही जिसका गाइड हो सकी।
Good evening, one and all. Welcome to the Aegeus Research Quiz of Conference 2021. This is the first of its kind quiz, and it's basically research in itself on whether this type of quizzes can be workable or not. So, welcome to our pilot study. So, today we'll be starting off with the objective rounds, which are the evidence-based round, biostats, pictorial round, and study design rounds, before we move on to critical appraisal and clinician's choice rounds. So for these two, the final two rounds, we have with us the judges. Let me introduce them. We have Dr. Smriti Pajpai ma'am, Associate Professor of Department of Medicine at Aegeus Medical College and KEM Hospital. We have Yashaswi Shetty ma'am, Associate Professor of Department of Pharmacology at Aegeus Medical College and KEM Hospital. And Dr. Amit Bondwe sir, Assistant Professor at Department of Community Medicine at Aegeus Medical College and KEM Hospital. Welcome to all the judges. They'll be joining us for assessment at 8 p.m. Before that, we'll be having all the objective rounds, which we hope to finish within the next 1 hour. As previously mentioned, the sequence which we'll be going by is team A, B, C, D, E, and F. With each round, the starting team will progress one step further. So for round 2, it will be starting with B. Round 3, it will be starting with team C. Is everyone ready? Just check your mics once and get a confirmation. Am I audible? Yeah. Team C is audible.
I'm audible.
Yeah. Team A is audible.
Am I audible?
Yeah.
Can you hear me?
Yeah, we can hear you.
Okay.
Good. Can you hear me?
Am I audible?
Yeah. Okay, we can hear you. Team D, your audio is coming in a little weak, but we can hear you. Okay. If you are ready, shall we begin? Okay. Okay. So you guys already know your team allocations. This is for whoever is viewing. So we have with us team A, Akash Sethi and Paras Matre. Team B, Manas Pustake and Mohammad Arfat Ganiani. Team C, we have Priyati Chopra and Brinda Pahuja. Team D, Vedant Shah and Jangala Sai Vihar. Team E, Omkar Shah and Abdur Rahman. Team F, Ahmed Ozair and Vivek Bhatt. So as mentioned, sequence of rounds will be starting with the evidence-based round, followed by the biostats, pictorial round, study design round, and the two rounds which are subjective and will be appraised by the judges is the critical appraisal round and clinician choice rounds. So let us begin with the evidence-based round. The first question will be to team A. The time per question is 1 minute. Correct answer gets you 10 points. Ignore the error in the description, that is an error. Incorrect answer will be -5 points. If you pass it, your team gets 0 points. And the team which answers the past question will get +5 points for the right answer and -2.5 points for the wrong answer. So team A, your question is as follows. A doctor is reading through a recent journal publication on accuracy of diagnostic tests for COVID-19. He finds the following details regarding the two screening tests he commonly prescribed to his patients. Test A has a sensitivity of 91.9% and a specificity of 25.1%. Test B has a sensitivity of 97.2% and a specificity of 90%. Based on this, the doctor has decided to modify his diagnostic strategy. Which of the following is the correct option to choose? Option A, stop test B and use only test A. Option B, stop test A and use only test B. Option C, continue using both the tests for diagnosis. And option D is look for newer tests. This is a single best answer type option. Question.
Your time has started.
The answer is option B. Stop test A and use only B.
Okay, let us check if they are right. Right. So 10 points to team A. Team B, are you ready?
Yes.
Okay. The question is as follows. An organization wants to implement a survey and treatment plan for iron deficiency anemia in a group of villages. Population is 53,200. It wants to find an effective method of measurement of hemoglobin to prescribe oral iron to the people being screened. It comes across an article which was a meta-analysis on non-invasive hemoglobin measurement. The mean overall difference found between non-invasive and invasive methods of hemoglobin monitoring was 0.23. It did not present statistical significance. The p-value was greater than 0.05. The results of the analysis of heterogeneity within and between the studies indicated high levels of inconsistency method for hemoglobin values. Based on this statement, we can safely conclude that A, non-invasive method is better method for screening. B, invasive method is the better method for screening. C, both methods can be used. And D, neither method can be used for screening.
Your timer started. Thirty seconds to go.
We would like to pass this question.
Okay. Team C, would you like to answer? Team C, if you can hear me.
Hi, we can. How much time do we have?
You have the same 1 minute.
1 minute.
Okay, Team C. Answer. You can answer now. Actually, we cannot have the same time for passing as well.
Yeah,
If you have an immediate answer, you can answer, or it will pass to the next one.
Yeah, we'd like to pass the question. Thank you.
Okay, Team D. If you have an answer right now, you can answer. Okay, Team E.
We would like to answer.
Okay, Team D.
We would like to go with option B.
Option
B, sir, B.
B. B for ball.
Ball, yes.
Yeah. Okay, let's check out the answer. The solution is option C, because the study meta-analysis reveals that there is no significant difference in the hemoglobin values which are measured by the two tests. So it doesn't matter which test you use for the screening. It actually depends on what cost is applicable for each of the tests, which is not a parameter we were assessing that. Okay, so team D gets a minus 2.5. Okay, so next question is for team C. A case control study looking into the effect of diet and consumed goods on ulcerative colitis severity had the following findings. Food and relative list. I'm going to read the table. A 0.65, B 1.0, C 1.3, and D 1.5. On the basis of this table, choose the correct statement. Food item B increases the severity of ulcerative colitis. Food item A decreases the severity of ulcerative colitis. 3. Food item C and D decrease the severity of ulcerative colitis. Food items C and D have no effect on the severity of ulcerative colitis. Team C.
Option 2.
Okay. Let's see the answer. You're right. So team C gets 10 points. Okay. Team D, are you ready?
Yes, sir.
Okay. It is found that a disease is associated with elevated levels of three proteins in the blood. Tests are performed to detect each of these, and an analysis is done to assess their positive predictive value. Protein A has a positive predictive value of 67%. For protein B, this is 75%, and protein C has a value of 25%. Based on this, which protein can be used in the diagnosis of this particular disease? Option A, protein B and C. Option B, only protein B. Option C, protein A and C. And option D is protein C. Team D.
Seconds to go.
Two.
I would like to go with option B. B for ball.
Okay, option B. Let's see if they're right. You are right, Team D. So you get 10 points. Team E, are you ready?
Yes.
Okay. So due to the non-availability for a substance K in the urine, which is the gold standard for the diagnosis of a disease, a doctor is looking for alternative substances to measure. They find the following table in a review article. So we have substance correlation with levels of K and P value. So A, B, C, and D. I'm going to read 0.667 and with a P value of 0.160, 0.256 with a P value of 0.002, 0.349 with a value of 0.003, 0.576 with a value of 0.005. Which is the best alternative substance to measure? Substance K. Substance, first option, substance A. Second is substance B. Third option, substance C. Fourth is substance D. Team E, your answers. Time starts now.
Your timer.
Option D.
Okay.
Sorry, option 4. Option 4, substance D.
Yeah, I understood. Yeah, you're right. So you will get 10 points. Team E gets 10. Okay. For Team F, 4 companies are exploring novel therapies for a rare disease. Initial trials reveal the following. For drug A, the number needed to treat is 9. For B, it is 11. For C, 7. And for D, it is 16. From the data in the table, which drug should be selected for further development? Option 1, drug A. Option 2, drug B. Option 3, drug C. Option 4, drug D. Team F, your time starts now.
Option 3, drug C.
Okay, let's check your answer. Option B. What are the chosen?
Is there some issue? It's a number needed to treat.
Yeah, one second. I think that.
Yeah, there is some issue.
Yeah, it's drug. It's option C. I think they'll get 10 points. There's an error in this. Okay, for biostats round, my teammate Muskan will be hosting further. I'll be controlling the presentation. Over to you, Muskan.
Okay, so these are the points for the previous round. Team A, 10 points. Team B, 0. Team C, 10 points. Team D 7.5 points, Team E 10 points, and Team F 10 points. So let's start with the biostats round. You will have 2 minutes per question. For each correct answer, you get plus 10 points, with 5 points for slide design. I'm sorry, that's invalid. So for each correct answer, you get plus 10 points. For incorrect answer, you get minus 5 points. If you pass the question, 0 points. And if the next group answers the past question, plus 5 points. So let's start. Team B. And if your past question is incorrect, you'll have minus 5 points. Sorry, minus 2.5 points. Team B, are you ready?
Yeah, ready.
Okay. Question 1. Drugs A, B, C are given daily to HIV positive patients at low dosage, moderate dosage, and high dosage. T cell counts were taken every 3 months for a period of 5 years. The test of significance to differentiate between proportions of T helper and T suppressor cells in the above scenario is A. Student's T test, B. F test, C. chi-square, and D. Regression analysis.
Your time has started.
Option is C, chi-square test.
Okay, let's check. Correct answer. Option C. Team B gets 10 points.
No, rationale has to be explained, right? Just to clarify, or not? Because the scoring rubric said 5 points for rationale.
Okay,
in the slide outline.
I can explain the rationale, but was that said before? As far as I am aware, this is an objective round.
Rationale doesn't need to be explained. You just need to give the answer.
Yeah, okay. So there was a conflict with the slide, yes. Slide mentioned plus 5 for
Yes.
rationale.
Yes. Team C, next question. Match the statements below with the contents of the table. So here is the table, and you have 3 options. 1, correct decision. 2, used to determine the power of the test. And 3, the investigator has some control of this error.
Time has started. You have 30 seconds left.
Option 1. Hello?
Okay, let's check. Correct option. Team C gets 10 points. Team D, ready?
Yes.
Okay. In a cohort study concerning the relationship between cirrhosis of the liver and the subsequent risk of hepatic encephalopathy, 1,000 adults were followed from 1986 to 1990. The results were as follows. Here is the table. The attributable risk in this study is
Your time has started.
Quizmasters, please ensure the time limits.
Yes, we are keeping time. Biostats round has 2 minutes per question.
You have 30 seconds left. Your time is up.
There's just 1 second now.
the question gets passed to Team D. Your time is up, Team D. The question gets passed to Team E. Team E, do you have the answer?
Hello. Hello, huh? So the answer is option D, 0.67.
This is Team E, right?
Team E. This is Team E.
The answer is wrong. You get minus 2.5 points. Team E, next question. To evaluate a new radiological scanning procedure, a group of 200 patients volunteered to be screened. Among this group, 100 were known to have the disease as confirmed by medical records. During this study, 130 were found to be positive for the test, of which 60 were false positives, and 30 of the 100 patients who were known to have the disease were false negatives. What is the sensitivity of the new scanning procedure?
Your time has started.
Hello. Option B. B for ball. 70 upon 70 plus 30.
Let's check. Wrong answer. You get -5 points. Team F, are you ready?
Yes. It should be -2. Achha, sorry. -5.
Team F, next question to you. Specificity for breast examination is traditionally rather high among community practitioners. If a team of new researchers set forth a goal to increase specificity in detection of breast cancer from the previously reported national average of 74%, based on the following results, has the team achieved their goal? The breast cancer screening results are given. Option A, no. The research team's result led to nearly the same specificity as the previous nation's average. B, yes, the team has achieved an increase in specificity of approximately 8%. C, yes, the team has achieved an increase in specificity of over 15%. And option D, cannot be determined as the prevalence of breast cancer is not listed.
Your time has started.
Option B, team has achieved an increase in specificity of approximately 8%.
Okay, let's check. Correct answer, you get +10 points. Team A, are you ready? Team A. Okay. A standard urine test used to detect cocaine has a sensitivity of 97%, a specificity of 94%, a positive predictive value of 90%, and a negative predictive value of 95%. Recent data suggests that the use of cocaine in all age groups has declined since the screening test properties were determined. A decline in cocaine usage will most likely have which of the following impacts on the results of the screening test? Option A, decrease the sensitivity. Option B, decrease the specificity. Option C, increase the negative predictive value. And option D, increase the positive predictive value.
Your time has started. You have 30 seconds remaining.
Yeah, the answer is D. D for dog.
Okay, let's check. Wrong answer. You get -5 points. So let me announce the results of the second round. After the second round. So team A gets 5 points, team B 10 points, team C 20 points, team D 7.5 points, team E 2.5 points, and team F 20 points. Now
Excuse me.
Yes.
Excuse me. Please,
Yes.
please revisit question number 4. I think the option is wrong. Please revisit that. Just
Okay.
once. Question number 4. The option is option B. Has anybody come to option B as well? I think
No, we are agreeing with option C.
you're agreeing with option C. Okay. Okay. Sensitivity.
Yes.
Does anybody else have a problem with this? Anybody else calculate this, please? Off the cuff, 30 seconds, just.
Okay, as of now, we'll move on. We'll
Okay,
come to
move
this.
on and revisit this, please, in the end.
Yes, yes, sure. We'll revisit this question. So we will start with the pictorial round. I hand over to Devansh.
Hello all. Am I visible and audible to everyone? Okay, I'll be the host for the pictorial round. You will be showing graphs and plots from published literature. Questions will be based on identification and interpretation of these images. Time per question will be 2 minutes. Each correct answer will be awarded with 10 points. Incorrect answer will be a deduction of 5 points. Past answer would be 0 points. Past answer would be plus 5 points, and a past wrong answer would be minus 2.5 points. So I'll begin with team C. Are you all ready?
Yes, we're ready.
Okay. Okay. So which of the following tests produces a plot as shown to the side? The Kolmogorov-Smirnov test gives a p-value of 0.041. The options are Wilcoxon-Sign-Rank test, Mann-Whitney U test, unpaired T test, and paired T test. Your time has started. You have 30 seconds remaining.
A, option number A.
If you okay, moving on to number D.
This is for us, for team D.
This is for team D. Okay, so below you will see two Kaplan-Meier curves graphed on the same set of axes. The curves are estimates of survival function for two groups of patients with diffuse histiocytic lymphoma. For group 1, you have 19 patients with stage 3 cancer, and for group 2, you have 16 patients with stage 4 cancer. Which of the following statements is correct? For option A, you have as the curve for the stage 3 group is higher than the curve for stage 4 group across the entire time interval, stage 3 patient in this sample have a better survival prognosis. Option B, as the curve for the stage 4 group is higher than the curve for stage 4 group across the entire time interval, stage 4 patient in this sample have a better survival prognosis. Option C, as the curve for the stage 3 group is lower than the curve for the stage 4 group across the entire time interval, stage 3 patients in this sample have a better survival prognosis. And option D is, as the curve for the stage 4 group is lower than the curve for the stage 4, the stage 3 group across the entire time interval, the stage 4 patients in the sample have a better survival prognosis. Please note the change in the last option. In the second sentence, it's stage 3.
In the second
your
sentence,
time has started.
Could you please repeat?
In option D, as the curve for the stage 4 group is lower than the curve for stage 3. The change is right here.
Okay.
Group across the entire time interval. Okay, your timer has started.
You'd like to go for option A?
Okay, let's see the answer. Yes, you're correct. Moving on to team E. Here's the question for you all. A funnel plot is a scatter plot of treatment effect against a measure of study precision. It is used primarily as a visual aid for detecting bias. Study the funnel plots given below. The x and y axes are given as follows. Select the correct statement. A arises from well-behaved data set in which publication bias is unlikely. B arises from data set that points towards publication bias. Option 3 is B arises from well-behaved data set in which publication bias is unlikely. Option 4 is B and C arise from well-behaved data set in which publication bias is unlikely. This is for team E and your timer has started.
We have 2 minutes, right?
Yes.
We are going with option 3. B arises from well-behaved data set.
Okay, let's see if you're correct. Yes, you're correct. Now, the next team. Team F, are you all ready?
Okay.
Here is your question. A meta-analysis was done studying the association between metformin and cancer mortality, and the following plot was generated. The first part, and give your interpretation for the same. Your options are as listed below. And your timer has started.
So it's option C, Liberty 2009 found a significant association.
Let's see if your answer is correct. Just a second, facing some technical issue. Please give us 2 more minutes. Now we will see if the answer was correct. Yes, you are correct. Now moving on to team A. Are you all ready? Okay, so the incidence and the prevalence of a disease X in females from age from 40 to 60 over a period of 10 years is illustrated below. Select the incorrect statement. Option A, prevalence of the disease is decreasing with time. Option B, prevalence of the disease is inversely proportional to the incidence. Option C, recovery from the disease is becoming rapid. Option D, the duration of disease is decreasing and incidence rate is fairly constant. Your timer started.
The answer is B. B for Bombay.
Okay, let's see if your answer is correct. And it is correct. Now moving on to team B. This is a question for you all. In a study, various infection markers were studied, namely PCT, CRP, and WCC. Interpret the following ROC graph and select the correct statement. Leukocyte tool compared to C-reactive protein. Option B, C-reactive protein is a better diagnostic tool compared to procalcitonin. Option C, procalcitonin is a better diagnostic tool compared to C-reactive protein. And option D, Procalcitonin is a useless test. Your timer has started.
The option is C. C for cat.
Okay, now we shall see if your answer is correct. It is correct. Okay, after this round, these are your final scores. Team A, 15 points. Team B, 20 points. Team C, 15 points. Team D, 17.5 points. Team E, 12.5 points. And Team F, a total of 30 points. Now I'll be handing over to Amir to take the study design round.
Hi. For the last round, wasn't the negative marking 2.5 points? Hello, am I audible?
Yeah, the negative marking was 2.5 points for past questions, not for your own question. It's -5 for your own question.
Okay.
This one is for team D, right?
Hello, this is Amay Kundavar, and I'll be hosting the next round, that is the study design round. So here you will be presented a clinical scenario or a research question. Considering all the provided data and intended study outcome, you will be expected to choose a single best study design for it. To note, consider all the levels of evidences for considering your study design, including the primary and secondary levels of studies. And here you won't have any options. Time per question is 1 minute. To note, correct answer fetches you plus 10 points, 5 points for the study design, and 5 points for the rationale to choose that study design. Incorrect answer gives you -5 points. Past gives you 0 points. If the past question is answered correctly, it gives you +5 points. And if it's answered incorrectly, it gives you -2.5. So here we begin with Team D. Team D, are you ready?
Yes, sir.
I have a doubt.
Yeah, please go ahead.
What if study design is correct and rationale is wrong by some means? Like,
then you'll get +5 points. There's no negative marking for that.
Okay.
Yeah.
And
to not mention, if you're, can you repeat? Sorry.
If one part is correct and the other part is not attempted, will the second half of the question be passed?
No, that won't happen.
Thank you.
Yeah. And of course, if your study design is incorrect and your rationale, however, is correct, you won't get any points. Yeah. So we'll begin with Team D, first question.
So the presentation is not visible.
Yeah, just a second. Just to make a note, this round only gives you 1 minute per question. Yeah. So the question for Team D is, a minimal access thyroid surgeon has recently started performing transoral endoscopic thyroidectomy via the vestibular approach, TOE-TVA. A patient was previously operated by TOE-TVA, presented with a bothersome pulling sensation along the surgical tract, particularly in the area immediately below the lower jaw. The surgeon figured that it was a complication as observed in 4 of the total 6 operated cases in the last 1 year. He also noticed that this technique offered relatively better surgical and cosmetic outcomes, which had been rarely documented before. What would be the best possible research design to explore the experiences, especially the pattern of complications in the patients he had operated in the past 1 year? Your time starts now.
Do you like to attempt?
Yes,
So
please.
the study design would be a case series. Our rationale is that as a surgeon, he's performed this surgery on 6 out of the 4 of 6 operated cases, and he's observed this complication in 4 out of these patients. So because there are more than one cases, so if it would have been a single case, it would have been a case report. But because there are 4 cases, so it is a case series, a descriptive type of study.
Yeah, that is a correct answer and almost correct rationale. I would just like to add that we cannot perform other studies because there is a limited number of cases, and also it's a rare condition. So case series would be the perfect answer. Yeah. So the next question is for team E. It was known that genetic polymorphisms were associated with diabetic retinopathy. An ophthalmologist and a pathology scientist together conducted a primary literature review to notice that the Z2 microsatellite was found to confer risk, odds ratio 2.33 with a p-value of 2 into 10 raised to the power -4 in type 1 and type 2 diabetes, and Z plus 2 to confer protection, odds ratio of 0.58 with a p-value of 0.02 against diabetic retinopathy in type 2 diabetes, regardless of ethnicity in one study. Multiple studies also showed polymorphisms in aldolase reductase, AKR1B1 gene, NOS3, VEGF, ITGA2, and ICAM1 to be associated with diabetic retinopathy. What should be the most suitable design for their further research in order to explore the association in a larger pool of sample and with maximum statistical evidence? Your time starts now. You have 30 seconds remaining.
Hello. So we would conduct a cohort study. The reason for that is in that we can explore the multiple associations that they are asking towards a common outcome. Plus, it asks for maximum statistical evidence. For that, a cohort study will be very good for this.
Let's see the answer. That is an incorrect answer. The best option would be meta-analysis after systematic review, because specifically we have asked for maximum statistical evidence, and as mentioned before, all the statistical levels of evidence should be considered. So after we have the data from various studies which have already been done, including cohort studies, meta-analysis after a systematic review would be the best option. So you get -5 for a wrong answer. Team F has the following question. A dermatologist finds a recurring diagnostic pattern of cases of women enrolled to a clinic with squamous cell carcinoma of skin to also have been previously diagnosed with systemic lupus erythematosus, SLE, and had undergone long-term prednisolone or methylprednisolone therapy. She hypothesized an association between long-term systemic steroid therapy and potential risk of squamous cell carcinoma. What should be the most suitable research design for testing the same? Justify your choice. Your time starts now.
This should be a matched cohort study, basically a 2-arm cohort study, because the cohort study allows us to draw causal inference regarding a risk factor and the outcome being this squamous cell carcinoma. Ideally, if they have time, we would go for a prospective cohort study, but if we don't, we can go for historically controlled cohort study as well.
I would please like you to choose one single answer. I would consider the first answer because that was answered first. So the cohort study is a wrong answer. the study to be chosen here is a case control study. Firstly, because the dermatologist here is assessing the same as the patients are coming here with squamous cell carcinoma, and the study is being conducted, the assessment is being done in a retrospective manner, and also the condition is quite rare.
No, I would disagree with that. The case control study, could you go back to the question?
Yes, please. Yeah.
Doing a cohort study allows us to test association at test association, and association is a big big Venn diagram, in part of which is causal inference.
So here, yeah.
So I'm saying this is let's say this is the association, and in that a smaller a smaller circle is of causal inference. So doing a cohort study allows us to answer both of explore association at a deeper level as well.
Okay. So as mentioned before, we have to consider the scenario at hand. Here, our question is, what should be the most suitable design for testing the potential risk of squamous cell carcinoma, and also to the hypothesized.
So risk, when we use the term risk, that is a term only used for, cohort studies, we cannot
use. It's better to have a discussion rather than a.
Pardon?
Okay, let's pass this question to the judges, or keep it for the later.
I mean, just, risk is clearly, it's well written that risk is only for cohort studies, and odds ratio is described for case control studies.
Team, we do understand your concern. We'll pass this question to the judges, so that because we have a paucity of time. Yeah. Thank you. The next is team A. A primary care physician has been working in a PHC since the last 6 years. A prevalence study he had conducted last year showed that 42.7% of the geriatric aged greater than 60 years individuals had depressive disorder. He observed that older adults of the village had frequent meets at a temple to discuss about their issues in life. During health checkups, these residents apparently had a better mental health than those not attending these meets. What could be the best possible study design for him to measure the impact of a structurally designed peer counseling program in the form of these meets, along with the psychopharmacotherapy they were receiving, on the depressive disorder status of the geriatric residents? Your time starts now.
This will be a randomized control trial, because it's written that he has a structurally designed peer counseling, and he'll be adding that to psychopharmacotherapy, and the other group will only be having the psychopharmacotherapy. So he will be able to find the difference between the two groups.
Yeah, team A, that is an absolutely correct answer with a perfect justification. The answer is randomized control trial. Next is the question for team B. Gastrointestinal diseases like inflammatory bowel disease, celiac disease, short bowel syndrome, and post-gastrectomy status are conditions associated with osteoporosis. Recently, H. pylori infection has been suggested to play a role in decreased bone mineral density, BMD. According to health statistics from a health database, the one-year mortality of hip fracture among elderly population was 16.6%, which is approximately 2.9 times higher than the general population. Many prevalence studies showed the association between the same. A team of gastroenterologists at a tertiary care hospital plan to investigate the longitudinal association of the two variables. What should be the most suitable study design? The time starts now.
Which two variables are you asking? It is not clear in the question. Association of the two variables, the last line, association of two variables, which two variable? Please clear that before starting the time. Which two variables?
So the two variables.
You are saying osteoporosis, then you are putting this bone mineral density in.
The two variables here are H. pylori infection and decreasing bone mineral density or hip fracture.
Okay, fine, fair enough.
I think it was pretty clear in the question. You have 20 seconds remaining.
The answer is a cohort study, and the rationale is that it is a longitudinal association, and they are assessing between these two variables in a longitudinal manner. So it should be a cohort study.
Yes, the answer and the rationale are correct. You get plus 10 points. The next question is for team C. An obstetrician was undergoing a fellowship for in vitro fertilization. A senior guide gave her the following instruction. We need to analyze the protective and risk psychological factors that could be associated with in vitro fertilization outcome. The best way to do it is to take the data prior to starting the IVF cycle only one time. We could use logistic regression for analysis of scores under PSS 10, COC, SOCS, CREOQ3, and scales. Start developing the protocol. What should be entered as a study design for this project? And give rationale for the same. Your time starts now. You have 20 seconds remaining.
Both.
Hi, we would like to tell longitudinal study design.
And do you have a rationale for that?
Yeah, because we are assessing the same group of people and in two particular formats, like more than once. Therefore, it will be longitudinal study.
That is an incorrect answer. Here, the best, considering what the instruction was given by the senior, the best answer here would be a cross-sectional study, because as it's clearly mentioned that the data has to be taken prior to starting the IVF cycle only one time, and the primary variable to be assessed at hand is protective and risk psychological factors, and not the in vitro fertilization outcome.
Yeah, but then it is not mentioned or anything about the thing after the analysis. We were, what we interpreted it as is that before the IVF, only once we are taking it, and then after the IVF, there would be another round.
I think it's pretty clear in the question. As it stated that the protective and risk psychological factors have to be assessed. So those are to be taken only one time before the IVF cycle. I hope this is, yeah. So you get -5. And that is the end of our study design round. We'll have the score.
Excuse me?
Yeah.
Round 2, question number 4. The answer is wrong. Please revisit it and I can explain it to you why it's wrong. There is no way that that answer was option C or whatever the answer was. Hello, am I audible?
Yes, please give us a moment.
Yeah, there is one query, excuse me.
Yeah,
Yes, go ahead.
Yeah, in the last question number 6, if you only collect data prior to starting the IVF cycle, then how can you assess the relation with any outcome? The outcome has not yet occurred. So, and you have specifically stated that in the study, you can only collect data only once, just prior to the IVF.
So here they are performing logistical regressions. The variable at hand is the psychological, protective, and risk factors. those will be assessed before taking the IVF, before starting the IVF cycle, and the outcome will be assessed. So these two things will be analyzed.
I agree with, but the outcome is not occurred. The cross-section study is supposed to be a single time point analysis, and if so,
we are not following a particular variable over a period of time. So it is not a longitudinal. And as you can see, the data of protective and risk psychological factors is taken only once before this IVF cycle.
But we are following up with the people who are doing the test, right? Even if it is not for the same variable.
Okay, because we have a paucity of time, let's have the discussion.
Yeah, I think, I support there, I support, they are correct.
I agree. Okay, fine. But
I'd
let's
also
talk about
like to speak about round two. The other competitor's been speaking about his question where he answered it correctly, but you mark it as wrong. I agree with him.
Yes, the sensitivity analysis, yes, they are correct.
It is 70 by 70
okay.
plus 30. The definition of sensitivity is true positive by true positive plus false negative, which he was correct.
So we got a -5 for
okay.
that.
Hello.
Thank you, Team
Hello.
F.
Am I audible? Am I audible?
Yes.
Yeah. So I would request all the participants to kindly be patient. If you have doubts in 2 questions, right, in this study design round, am I correct? And 1 question in the biostatistics round.
Yes.
Biostats, you can do it. That is 100%. The answer is wrong.
So biostatistics.
Can you show that question again?
Yes. Wait. Let me complete. Please have patience. Yeah. So we agree that the biostatistics question was wrongly marked. We just said that let us address this question later, just because we are running out of time. So
Just please show the question. I object.
Wait, your answer that you're telling that the option was marked wrong, we agree to that, and the option that you are telling is right. Now wait a minute, let me complete. The other
No,
2
you are
things that
saying
you are
that
mentioning
you are
about.
correct. Quiz master's answer was correct. Side.
Yes, I am.
I really request all the fellow teams to please be patient, as Shirish is saying. All the doubts will be cleared consecutively.
We
Please
we have a jury of judges with us. I would kindly request one of them to address the 2 doubts which have been raised in the study design round, and we will take them at the end of the quiz. So kindly be patient and adhere to the rules, otherwise you would be disqualified.
Hello, am I audible? Hello.
Yes, ma'am, you are
Shirish,
audible.
am I audible?
Yes, ma'am, you are audible.
Yeah, so what I would suggest all the participants, as Shirish, the quiz master, is repeatedly telling you, have patience. We have understood your grievance. We have tried to rectify it, and your final calculation will be at the end of your quiz. So I understand that, but please don't, you have to have some decorum as well. And that's what Shirish is telling you. Has anybody told that you are wrong now? We are telling, okay, we will address your question. So I think so if you'll keep on doing this, you'll just extend that time frame and will further delay the quiz, which will not be correct. So now let's go on with the quiz, and these issues, both of them will be dealt before the quiz ends. Okay. And in future, if anything like this arises, I would request that you need to mute all of the participants if this chaos continues. I will end myself now here.
Thank you so much, ma'am. We may proceed with the quiz now. Yes, please continue.
Okay. As of now, the scores standing are Team A 25 points, Team B 30 points, Team C 10 points, Team D 27.5 points, Team E 22.5 points, Team F 25 points. All of your doubts and queries will be addressed at the end of the session. For now, we head into the critical appraisal round, wherein all the teams will currently be sent to breakout rooms in Zoom. You will be along with your teammates until you are called upon. So currently, all teams other than team E will be heading to breakout rooms, and team E, your presentation will be starting just after my address ends.
Could we have a short break for 5 minutes?
Yeah, okay. Team E could have a short break. So everyone could have a short break, but we'll be putting you into breakout rooms right now.
Will you be sharing those breakout rooms on WhatsApp or what?
Breakouts room would be automatically distributed via Zoom.
Okay. Okay. Hello, am I audible? Is this breakout room that team E is supposed to be in, or is it some other breakout room? Hello, am I audible?
Hello? Yeah, go ahead. Could you repeat?
Is this the breakout room that team E is supposed in, or where is
Team E is supposed to be in the main room.
which room?
Who's speaking? 1 second.
Team E. I'm team E. I'm speaking.
Okay.
And we're supposed to go first. So what I'm asking is our breakout room this room, the main room, or is there a separate room which we're supposed to go?
No, team E,
Because
you are
all
supposed
the
to
other
you are
teams-
supposed to be here in the main meeting.
Okay.
You're supposed to be here in the main meeting, and you'll be presenting to the judges here itself. Once you are done with the presentation, you'll be staying on in the main meeting, and we'll add team F to the meeting after that. Is that clear?
Okay. The other teams are not supposed to be here right now.
I'm sorry, I missed some part of it. My computer restarted.
Yeah, so we'll be assigning you to breakout rooms in Zoom itself. You'll be with your teammate. So team E, I hope the break has been enough. Would you like to start presenting?
Yeah, sure. I think team C is still in this room.
Are you able to start screen sharing?
Yes, I think C is still inside the meeting. That's what I'm saying. The other teams.
1 second.
Team C is seen in the group.
Yeah, they have not joined the breakout rooms yet. Yeah, okay.
Okay.
Now they are gone. You can start presenting.
Okay. Hello, is the screen visible now?
No, it is not visible yet.
Yeah, it's not yet visible.
Okay.
Yeah, we could see it for a moment.
Okay, okay, that's fine. Tell me when it.
You can see a black screen right now with all your sharing options.
Team C is seen again. Team C. Yes.
This is team E.
Yes, ma'am. We are putting them in the waiting room.
Yeah.
I can see the article.
Okay.
Ma'am,
Okay,
all of you could you see the article? Ma'am, are you able to see the article?
Yeah, we can see that. Yeah,
Okay.
we can start.
Team E, you can go ahead. You have 6 minutes.
Okay, thank you. Good evening. We are doing a research article by Team E. And start So in terms of basic study design, the research question was basically assessing the two groups. Research question was focused in terms of patient studied and in the measurement of outcomes. The patient studied the adults attending the UPNHS stop cases and the measurement of outcomes being the outcome being 1 year stayed abstinent and validated biochemically by expired carbon monoxide levels. And there are a number of secondary outcomes such as sustained abstinence at weeks 4, 26, and 26 to 50. So these measurement parts, the research.
Team E, if your internet connection is not stable, you could send us the PPT and we'll present it.
Yes, I'll just inform my partner. I don't think he can.
Or if you can present it on the behalf of your partner, would also be fine.
Yes.
Just either send us the PPT or we'll.
Yeah, really sorry for that.
Hello, am I audible now? I think I lost.
Yeah, you're
connection for just
audible.
a
I
second.
think your internet is not very stable. So if you could just send us the PPT.
Okay, okay. Just give me 5 seconds. Just give me a
Send it
minute.
to me. I'll just download it
Yes.
and play it for you.
Okay, okay. Thank you.
Judges, thank you for your patience. We are facing a lot of technical issues today.
So I have to send it to Yash. Are you Yash? Who am I talking to?
Yeah, you have to send it to me, Yash.
Okay. Okay. Yash, did you receive that? It's a PPT named Critical Appraisal Final.
I have received the PPT.
Okay.
Please wait, I'll be sharing it soon.
I do apologize for the connection issues.
No, it's okay, it's understandable. We are having rains everywhere.
So will our time will restart, right? Or it has been paused or something?
Yeah, your time will restart. You have to start explaining the study from the beginning. We'll soon screen share. Okay.
Okay. Thank you.
Is the screen visible to all?
Hello. Yes, the screen it's visible to me.
Yeah, it's visible. It's visible. Put on this thing on slideshow.
Yes, ma'am.
Yeah.
Okay, team E, you may begin.
Can start, please. Your time starts. Yeah.
Team E, critical appraisal of a randomized control trial. Please, next slide. So it's a randomized control trial of cigarettes versus nicotine replacement therapy, where e-cigarettes is the intervention and the nicotine replacement therapy, which are the nicotine replacement products such as gums, they are the comparator group. Next slide, please. So the research question, in terms of research question focus, whether it was appropriate or not, it was focused in terms of the population that it studied and in terms of measurement of outcomes. The population that was studied were adults attending the UK NHS stop smoking services. The population was well defined and the outcomes which were measured were also well defined. The primary outcome being 1 year sustained abstinence as per the Russell standard, which was validated biochemically by expired carbon monoxide levels.
जल्दी
outcomes,
हम बिल्कुल लाइट बंद कर देंगे और बुला देंगे हुजूर साहब
mic is on.
जल्दी डालो
Yes. So secondary outcomes included.
Smriti, you have to mute yourself.
Yeah, ma'am is muted. You can continue.
Okay, thank you. Secondary outcomes which were studied were included sustained abstinence at weeks 4, 26, and 26 to 52 weeks. These were all self-reported and these were all validated biochemically by expired carbon monoxide levels. Next slide, please. So in terms of population, which we just discussed, it was and outcomes, it was well focused. In terms of the intervention given and the comparator group, it was broadly focused, but it was not entirely specific. We say that because in the intervention group, second generation refillable e-cigarettes were given with nicotine e-liquid. The starting strength was measured and it was given to them for the first 3 months free of cost at 18 milligrams per ml strength. However, subsequent liquid strength was bought by the participants as per individual choice. So basically the dosage in the intervention group is not well defined because it will vary by individual choice. In the comparator group, nicotine replacement products or combinations thereof were given. These were again as per participants' individual choice. So in terms of broad grouping, they're all nicotine replacement products, but can a product which was a nicotine patch, whether it was a nicotine gum, that's not well defined. It was up to individual choice. So here neither the product nor the dose is well defined. So that is why in intervention and comparator groups, the question was broadly focused but not specific. Next slide, please. In terms of randomization, it was carried out by a pseudo-random number generator, and it was sufficient in systematic biases in distribution of all measured baseline characteristics at the start of trial. This is a quote from the study, and there are no significant differences found between the trial groups at baseline. For example, for all the measured characteristics at baseline, they were comparable, and these were some of the baseline characteristics: median age, female sex, employment, entitlement to free prescriptions, number of cigarettes per day, expired carbon monoxide levels, Fagerstrom's test for cigarette dependence, past use of nicotine replacement products, as well as past use of e-cigarettes. In terms of allocation sequence, it was concealed from both investigators and participants. And we'll talk more about randomization sequence in the following slides. Please next. Losses to follow-up were accounted for in study design, and patterns were analyzed in addition to analysis. Again, these are broadly what's there. We'll talk more about it. In methodology, allocation was concealed from both participants and investigators during recruitment and initial counseling, right up to the quit date, to avoid differential dropout. What they mean by this is because there was a concern that the participants allocated to the one of the groups, that is the nicotine replacement groups, they would not be so enthusiastic and they would drop out right in the beginning. To avoid this, allocation was concealed from them. However, it could not be blinded because of the nature of the study design. Participants were not blinded to the intervention due to the inherent of use of e-cigarettes and nicotine replacement products. They would always know what they were using. Assessment regarding abstinence involved a self-reported questionnaire, and the investigator involved in this was not blinded. The investigator collecting the data would obviously know in regard to the questionnaire what the. Next slide, please. Again, this is just an explanation of the past assertions. Product assignments could not be blinded. However, there were some measures taken. For example, positive expectations have limited effects on long-term abstinence. But if nicotine replacement was seen as an inferior option, participants in the nicotine replacement group could have put less effort into the quit attempt, those in the e-cigarette group. This is why differential dropout was a concern. Interview asked about product use and thus were aware of treatment assignments again, and data analyses were conducted blind to treatment assignment. So in this, the interviewer is not blinded, the participant is not blinded, but the analysis of the data, the person, that he is blinded. This could have led to significant performance bias amongst the participants because of lack of blinding. Attempts to reduce this were taken. Slide, please.
Yeah, you have 1 minute left, so kindly wrap up fast.
It is unclear whether the investigators involved in the biochemical carbon monoxide analysis were blinded or not. This could have led to detection bias. Next slide. Randomization was carried out by stratified randomization. Again, this is the sequence 1:1 in permuted blocks of 20 as per software. Baseline characteristics were comparable as we have seen, and stratification according to trial sites was taken into consideration in the analysis. As we have said, allocation concealment was maintained. Next slide, please. In terms of conduct, there was no significant deviation from the proposed plan. A change in delivery device occurred because of discontinuation of the device by the manufacturer, but no significant deviation was expected due to this. There was attrition. It was 18.9% in the e-cigarette group and over 20% in replacement products. To account for this attrition, all participants must follow up to be non-abstinent so that they would not spuriously increase the difference between. Next. There was a clearly defined study protocol, and after experimental interventions, both groups received the same level of care. Next slide, please. There was a mixing which occurred, and they counted for this by excluding those which actually used both. So there were some participants who used both the products. They were excluded in post hoc analysis of participants. Next. Intention to analysis was done, and as the analyses were adjusted for trial center, they were adjusted for baseline covariates using a stepwise. the standardized linear model which was used to estimate relative risk. Next. These are some of the details of the analysis. Sensitivity analysis were conducted, and non-assigned product using for at least 5 consecutive days was defined as exclusion. Mean differences was calculated, confidence interval was calculated, and regression was assumed for center using status software. Next slide.
Your time has exceeded by 1 minute. We had given you 1 minute extra, so your time is over. You can wrap up now. Just will give you some time.
So relative risk was measured, confidence interval PUs were measured, absolute was reported. Results were also reported in each study group at each follow-up. Next slide. Was undertaken, outcomes were clearly specified. There was a limitation that carbon monoxide validation is only valid for the past 24 hours. Next slide. Cost effectiveness was not undertaken. Patients were compensated for their time. Safety evaluation was carried out. There were 2 deaths and serious adverse effects, but none of them were attributed to product use. Next slide. Generalities were all urban centers in the London, and it also required active participation from the point to register. This have led to selection bias. Next slide.
Okay, I think now we should move over to the judges, whether they want to ask any questions on the presentation.
Sure, sure. I think the presentation is also wrapped up.
Yeah.
Thank you.
Judges, would you like to ask any questions?
Do you feel any ethical issues in this protocol execution, and what are they, if you feel?
So, one ethical issue which could be said was that cigarettes have their own side effects, and which is why they were banned later. This study was conducted in 2019 and on to 2020. And so one of them is that, however, at that time they will know. And an ethical issue in this might be that the participants might think that e-cigarettes are safe because they are being used in a trial, and also the assumption at the time was that e-cigarettes are superior, which is why there was concern for eventual dropout. So this is one ethical maybe.
What is the impact of variability in the product use? Does the variability has an effect on the outcomes? Because they were given a choice, like you can use your own preparation for nicotine patches as well as for others. And in nicotine also there's varied uses. Are there any differences in the preparation of nicotine used? Can they be used like that in varied preparations? Is there a scientific basis for that? And what is the impact on that, on the results, if there is variability?
So nicotine use, so for example, there are many nicotine replacement products, again, gum, patches, sublingual tablets, and a difference in a difference which could lead to is, for example, sublingual tablets are very fast releasing. So they give a quicker high and satiate addiction faster. So one of them is that, again, higher strength would satiate addiction faster. Nicotine patches are slow acting. They have been used, they were considered the gold standard in nicotine.
Okay. We have time for one more question, after which we have to go ahead with Team F. Smriti ma'am or Amit sir, would you like to ask a question?
No, it's okay. No questions from mine.
Don't have any question on this.
Okay, so Team E, stay with us. We'll be adding Team F on the call.
No. Can I ask one question more?
Okay. You can go ahead.
So you said, like, the person who is doing the analysis was blinded. What is this type of design called as? What type of blinding this is?
Ma'am, usually if the participant and the investigator and the assessor are blind, then it becomes a triple blind. But in this case, the participant and the investigators were not blinded. Only the assessor was blinded.
So what is that called as? That is what I'm asking. It is not a double blind study, nor it is a single blind study. So what is this blinding called as? There is a term for this type of blinding. So if you don't know, we can pass and we can go to the next team. Thank you very much.
Yes, ma'am. We are
Yes?
letting Team
Yeah,
F join now.
Yeah, surely.
Team F will be joining and presenting now. Team F, can you hear me? You can unmute yourself.
Yeah, I can hear you. Can you hear me?
Okay, one of you has to present. The questions can be answered by both of you, but only one person can present. And you have 6 minutes for the presentation.
My
Once you
teammate
start sharing your screen, your time will be started.
Yes. Okay. I'm just give me 1 second to share my screen. Thank you.
Yeah. Okay. Go ahead.
Can my screen?
Okay, you can start the presentation. We can see your screen.
Hello, everyone. My name is Ahmed, and I'm from presenting this critical appraisal from Team F. Today, we shall be going over this publication, Family History of Gastric Cancer and Helicobacter pylori Treatment, which was published in NEJM last year in January. Let's first do a summary of the paper. This paper, in this modified intention to treat analysis of a single center randomized double-blind trial, took 1,676 patients who had a diagnosed H. pylori infection on biopsy, and they had a first-degree relative who had gastric cancer. The study only enrolled patients from South Korea and divided them into 2 groups, H. pylori treatment and placebo, with H. pylori treatment arm receiving 7 days of lansoprazole, amoxicillin, clarithromycin combined therapy, and the placebo receiving only placebo groups. After which they followed up patients for a median follow-up of 9.2 years, and they saw tracked the incidence of gastric cancer. They found there was a significant difference in the cumulative incidence of gastric cancer with a hazard ratio of 0.45, with a confidence interval of 0.21 to 0.94, with the results being significant. However, there was no difference in overall survival. They concluded that H. pylori treatment in people who have H. pylori infection and a first-degree relative diagnosed with gastric cancer reduces the risk of gastric cancer. I'll now be critically appraising the study based on the CAS checklist for a randomized control trial. So firstly, was this a well-focused research question? Yes, there was equipoise at the time they started the study in 2003, 2004, and they had a clearly written PICO with regards to the same. At that time, it was unclear whether H. pylori infection eradication resulted in decrease in gastric cancer. However, one concern is that the American College of Gastroenterology Guidelines 1998 recommend clarithromycin therapy, which they used for 14 days instead of the 7-day intervention that they used, and this may have impacted the results. However, this would have only, if they had carried out for 14 days, it would have only bolstered the results and enhanced the H. pylori eradication rate, which was not 100% in this study. Was the randomization adequate? Yes. There was a random sequence generation and was sufficient to eliminate bias based on the baseline characteristics table. The allocation was concealed. Were all participants accounted for? No, there was some loss to follow-up. But this occurred after the randomization immediately and not after starting treatment. And they have done sensitivity analysis to demonstrate that this did not impact their outcomes. If you can see, 80 had no follow-up data after randomization in the treatment arm and 70 in this placebo arm. But this does not impact the data because this occurred just after randomization. An intention to treat analysis along with a modified intention to treat analysis was done. Study was completed to the end and there was no early stopping. This was a triple blinded study because they also blinded the statistician and the statistician, and thereby classifying as a triple blinding. Both groups were similar as per their baseline characteristics table, but one concern is they did not include older patients. They had they excluded older patients beyond 65 years of age. And we know that gastric cancer is disease of old age. The other concern is obesity and BMI should have been measured because this is a risk factor for gastric cancer and they did not report it or measure it. This is not reported in the supplementary table as well. Both groups received an equal treatment, and this was clearly defined in the study protocol. There were no additional interventions in the treatment arm, and the follow-up intervals were similar. Yes, the results were reported comprehensively. There was a proper power calculation performed. Outcomes were measured and clearly specified, and they did not change their primary and secondary outcomes from those that they had reported in the protocol. Results were reported appropriately in consistency with the reporting recommendations from the American Statistical Association. There was no differential dropout rate between the treatment arm and the placebo arm. They covered the potential source of bias well, and p-values were reported. There's one concern that non-gastric cancers should have been an endpoint or something that should have reported very clearly in the main paper, as supplementary table shows there was an increased incidence of hepatic and pancreatic cancers in treatment group. This was likely due to gastric dysbiosis in patients who received the H. pylori eradication therapy, which may have given rise to these cancers, and this should have been reported and very clearly stated. However, this was not done in the main paper. They did estimate the treatment effect precisely, and confidence intervals of the hazard ratios was presented. However, there was no significant difference for the overall survival. The benefits were, yes, more than the risk, because only mild adverse effects were reported as per the CTCAE grading scale.
You have 1 minute left.
And the results were applied to the local population. The only problem is that co-evolution of H. pylori has occurred in different worldwide races and regions, as the impact of intervention varies. Their introduction doesn't state the prevalence of H. pylori in cancer stomach in South Korea. Their seroprevalence is 50%. Our seroprevalence is around 27%. And yes, the experimental intervention does provide a greater value. So this is the summary, and thank you for the study. Yes, this study is practice changing, but the impact of intervention is limited.
So again, the placebo control arm is justified in the study. If you see the duration of study, what was the standard of care that time for H. pylori infection? Was that justified?
No, this was not fully justified, because in prior guidelines from American College of Gastroenterology and the European Gastroenterology Society had already said that H. pylori eradication therapy should have been should be given. But the other point is that, which was unclear at that time, should asymptomatic H. pylori carriers be treated? We are now clear that this should not be done, and only asymptomatic people should not be treated, and only symptomatic people who have symptoms from H. pylori should be treated. But that time, this was not very clear.
No, but asymptomatic patient never present to OPD, isn't it? You don't do a gastroscopy in an asymptomatic patient anyways. Asymptomatic patient will never come to your OPD unless there is some other
but in their inclusion criteria, they excluded all patients who had similar GI complaints.
Why they did not do an interim analysis? Because the studies for 9 years. Why there was no interim analysis? So when you saw the groups, the risk actually increased in the placebo arm, but there was no interim analysis. Yeah.
Yes, that is correct. And in their protocol, I looked at the protocol, and the DSMB did not. They reported that their DSMB did not make any recommendation regarding interim analysis, which ideally which should have been done ideally.
No, I agree. They cannot justify the placebo here. So that is one of the major.
Yeah, major thing. And no, if it were interim analysis, or then what would be the sample size, and what would be the power of the study with this analysis?
Yes. So if we had a pre-specified interim analysis, if that would have been planned, then because we are doing multiple hypothesis testing, one at the end and one at the interim analysis, so the sample size would have been higher. But this would have advised, for example, is it ethical to carry out this study further and expose the placebo group to a higher rate of risk by not giving them the standard of care?
No, other way around. My proposition is they should have taken a adaptive design. So when they understood the risk in placebo arm is increasing, they could have collapsed that placebo arm, and they could have continued with the Helicobacter treatment arm. So they could have put that placebo arm into the treatment arm, and then they would have seen, in between when the treatment starts, how much is the risk reduction. See, they have justified saying that it is stage 2 hyperplasia, but the stage 2 hyperplasia later in time will lead to stage 3, which doesn't have any treatment at present. So what I felt from this paper, and that has to be spelled out by you as an unethical thing in a loud thing, because one is that arm was not acceptable? If it was acceptable, then at what time point the concomitant medication should have been started? Why there was no interim analysis? Now, these are all ethical issues in this study. And fourth is why they did not collapse that arm when the risk increased, even if they did not do interim analysis. So you know where the data is heading. A statistician usually come to know where is the data heading. So that is what is my concern in this study.
Hello.
So I have a question.
Okay.
Can the presenter explain why the study is a triple blind study?
Yes. So it is triple blinding refers to the blinding of the treating doctor, the patient, and the statistician who is analyzing. So that is why it's a triple blinded study.
But the article is mentioned it is double blind study.
Yes. So current standard typically double blind study uses more conventionally reported. But yes, if we look at their method section, it is a triple blind study.
Yeah,
No,
that's where I'm looking at.
Yeah, so that's his question is, how do you justify that? Why do you think they have used it?
Yes. So
it is, yeah, carry on.
Yes. So allowing a triple blind study design further reduces the risk of bias being introduced by the person who is analyzing the data. So because you see they have done an intention to treat analysis and a modified intent to treat analysis, and the results slightly vary between the two analyses. So it's ideal to do a triple blinding, but the conventional term that at that time which was utilized was a double blind study, and this is what NEGM, there is an NEGM style guide which recommends use of double blind and single blind.
Ma'am, we'll wrap up now. Team A is going to join us.
Okay, fine.
Okay. Thank you, Team A. Team A will join
Thank
us
you.
now. You can stop sharing. Hello, Team A. Can you hear me? Team A?
Yeah. We can hear you.
Okay. Who's going to be presented?
Just a second.
Once you start the screen sharing, you will have a 6-minute timer, after which will be followed by 4 minutes of questioning.
Okay. Yeah, I'll share my screen. Can you see my screen?
No, we cannot see your screen.
Not yet. Not yet.
Yeah, we can see it.
Now we can see it.
Okay, perfect. Can you see the PDF I've come up with?
Yes, we can see your PDF. Should we start your time now?
Just a second. I'll set one time as well. Yeah, you can start in 3, 2, 1. Good evening, judges. This is Team A. The title of the study we had to critique was Changes in Prevalence of Healthcare-Associated Infections in the United States Hospital. We have divided our critique under 4 categories. Firstly, the study design. Secondly, the methodology. Thirdly, the results. And lastly, the interpretation. Firstly, we believe that a point prevalence study has a potential to overrepresent hospital-acquired infections of longer durations, such as the surgical site infection, since on any given day, patients with such infections are more likely to have signs and symptoms of these disease and or be receiving antibiotics, as compared to diseases like UTI, which have a shorter duration. Coming to the critique we have with the methodology, the study mentions that 10 sites which were a part of the emerging infection programs were recruited. However, they have not mentioned the sampling in detail, That is, they have not mentioned as to how these study sites have been arrived at, if they are representative of the general population, or how the sample size was calculated by providing no formulas for the readers. The second issue in the methodology we have is the ethical issue. We believe that the study says that the ethical clearance has been granted by hospital review boards, either giving them the title of a non-research activity or a waiver of informed consent. However, the ethical committee clearance statement hasn't been mentioned explicitly, which could look like that the hospital review board of XYZ has approved the study. Secondly, just below you can see that program sites reviewed medical records on the survey date or retrospectively to collect basic demographic and clinical data. We think that when demographic data has been collected and there has been no mention of participant de-identification, we think this study might be unfit for the waiver of an informed consent, as the participants could be traced back. The third issue we have with the methodology is that the study only mentions that we repeated the survey in 2015 to assess the changes in prevalence of HAI. However, they have not mentioned the particular study hypothesis they have tried to solve with this study. Coming to the issue with the inclusion criteria of this study, they have mentioned that they will include those cases where in a particular day, either the antibiotic was given or was planned to be given, or the patient had signs and symptoms of HAI. We think that when this happens, practice changes of the hospital could prevent detection of active HAIs. For example, substantial change in medical record documentations of signs and symptoms of antimicrobial prescription could affect their ability to describe HAI. This is extremely important, especially when the study is discussing the difference between a past event and a present event, where the present event would be biased with the emerging technology. We therefore think that a better criteria could be to select patients from all wards who develop signs of HAI post 48 hours after admission or had risk factor for developing HAI like catheterization. And this is in line with CDC's definition of HAIs. Coming to the issues that we have in the result of the studies, they have mentioned that 12,000 patients in 200 hospitals were surveyed. However, the number of individuals at each stage of study, for example, number which were potentially eligible, number of patients which were examined for eligibility, and those who were included in the study finally, if a flowchart would have been used, it would have been much better in this case to understand how patients were selected, especially given this is a multi-centric trial, point prevalence study. The second issue the other issue that we have with the result is that AP Meg had found that the Rame and Sudhart formula for calculation of prevalence from incidence could be problematic. However, the authors have used this formula to calculate the incidence. The main issue with this formula, if I have time, I'll be describing it, but for now, I'll be skipping this part. The adjustment which were done in this study were adjustment for age, time since admission, presence of device, and status of being in a large hospital. However, we think that as per Palanche and Polage, one of the major outcome modifier in case of hospital-acquired infection detection is the use of nucleic acid technologies like PCR. The authors have not mentioned if they have accounted for this potential factor change, which could have skewed the result.
You have 1 minute left.
Similarly, surgical site infections could be overestimated owing to greater number of surgeries being conducted in the hospital. Therefore, we think that a better way to estimate the prevalence of SSI could be the total number of patients developing SSI versus the total number of patients. That is the ratio of patients developing SSI versus the total patients who underwent surgery. Coming to the last point we had in the interpretation, the authors mentioned that these results provide evidence of national success in preventing HAIs. However, as I've pointed earlier, the authors have mentioned nothing to prove to show to the readers that the sampling technique they have used is representative of the general United States population. With this, we would like to thank you for your patience.
Your time is ending. Judges, you can start with your questions.
So you talked about demerits of this paper. What are the merits?
Yes, the merits of this paper would be that this is the study which talks about the point prevalence, and using point prevalence is conducting a cross-sectional study is one of the cheapest way to find changes, and especially when they've used a longitudinal data, it means they can compare two different groups. And if similarly cohort would have been done to compare different points in time, it would have been much costlier study. So the cost effectiveness would be one of the merits of this study. And the other merit of the study is that it's a multi-centric study. So they have included multiple hospitals.
I would like to add on to the merits. They have also done a regression analysis at the end, which I feel is a merit to the study.
So another thing you said in ethical issues that, the waiver of consent is not justified. But if you see US guidelines regarding independent ethics committee functioning, the data, which is tapped from the OPD papers or IPD papers, they give waiver of consent. So it depends on the local guidelines of that country. So US actually has that guideline. So how it is unethical then? So it depends on your SOP and the country guidelines, isn't it? So I don't feel it is an unethical thing, So yeah, that is what I understood from what I read. Because when you criticize the paper from a certain country, you should know the guidelines which they are following. And accordingly, you have to criticize it is ethical or unethical. Okay, for example, if you take a waiver of consent, what happens to the patient issues? What is the ethical issue in that?
Ma'am, so ma'am, the waiver of consent, which means that the patient is not being informed of the harms of the study or how this data will be processed in future. So especially when we talk about hospital-associated infections or any infection in general, which could range from HIV as well, that's the one important issue which could arise in this when waiver of consent is taken.
No, but how would that change the, patient's outcome? In this study,
yes, ma'am.
What would be the harm if you don't take a waiver of consent? What would be the ethical harm to the patient?
I'm sorry, the ethical harm if waiver is taken.
Yeah. See, you're saying this study has asked for waiver of consent, okay?
Yes,
and which I also agree that it is okay. So you feel that that's not correct. So we want to know from what aspect do you feel it's not correct?
Okay, ma'am. So, ma'am, as per the ICMR biomedical guidelines, which are a representative of the international guidelines, they have mentioned that only 6 criteria under which waiver of consent could be taken. So this does not fall into that. But coming from another point of view, it could be that when patient is not told that because there is issue of HIPAA as well in USA, where this data can't be given except for public health purposes. So they have not justified that this is under the HIPAA exemption. So that would be a legal issue as well.
In what form?
Ma'am, whenever patient's data is being taken, it's basically the patient's data is extension of his autonomy. So when autonomy of a person has to be taken, it ought to be justified with a greater good to the public, which hasn't been done. So this is an assault on the autonomy of the patient.
Okay.
We have time for one more question.
So do you not feel that there is a community benefit versus a personal benefit? So it is called as indirect benefit in ethical term. So that is more in the study as compared to personal benefit. So at that time point, you can take waiver of consent. Again, ICMR guideline is not an international guideline. It is a national guideline. Okay. So it is only pertaining to India. It is not followed in US. Okay.
Yes, ma'am. I agree to
that. Is this data irrelevant in the Indian context? Can we do? Is there such study in India?
Yes, ma'am. I had found studies back. I was planning ICMR based study to study HAIs. So they had done one study which was in South India, where they had rather done a cohort where all the patients who were admitted had any risk through devices. like they were catheterized or central line were inserted, they were followed up, and there the relative risk was calculated in that study. So however, I have found cohort studies from India, but I could not find a point prevalence based studies which compares 2 years.
Yeah, thank you
Okay.
very much.
Ma'am, we'll be letting in the next team now. Team B will be joining us soon.
Thank you.
Team A, you can stop presenting. Team B, can you hear me? Am I audible to you?
Yes, sir.
Okay, so from the moment you start presenting, you will have 6 minutes. One of you has to present, after which it will be followed by 4 minutes of questioning, during which both of you can answer.
Okay.
So once you start screen sharing, we'll start your timer.
Good evening, respected judges and organizers. Today we are presenting the critical appraisal of a cluster randomized control trial. The title of the published research paper is Community-Wide Screening of Tuberculosis in High Prevalence Setting. The author names are here, and the paper was published online on October 3rd, 2019 in New England Journal of Medicine. Now, it was a community-based cluster randomized control trial, and the aim of the study was to assess the effectiveness of a community-wide active case-finding intervention in reducing the prevalence of tuberculosis and tuberculosis infection in high prevalence area. The paper was rigorously peer-reviewed, as we know, the policy of New England Journal of Medicine. And coming to the purpose of the study, was the purpose of study stated clearly? Yes, the purpose of study was stated very clear. They were authors were very clear about what they're going to find. And now coming to research question. Now the research question of this study was: is a community-wide active case finding intervention effective in reducing the prevalence of tuberculosis and tuberculosis infection in high prevalence area? Now here comes the tricky part. Now here they have said in high prevalence area. There are no references for high prevalence area, no exact population they had defined what high prevalence area will be, and this is taken from that original paper under Creative Commons License 4. Now, evaluation of critical appraisal topic, we used a critical appraisal skills program, CASP. It is a critical appraisal tool that provide guidelines for assessing randomized control trials. We employed this tool for critically assessing this paper, appraising this paper. Here are the merits and demerits of this tool. And background literature, coming to background literature, background information, which was both clear and persuasive. In the introduction section of the article, the study had correctly highlighted the gaps in the literature, indicating that active screening is the only way or a possible solution for employing the World Health Organization's AIM-TB strategy. Now comes the most important part, study design. The study was designed as a cluster randomized trial. Now here we focused on to this because it was a community-based study. So cluster randomized trial was a good option. It was the preferred design for this type of study. In fact, if it was an individual trial, then randomized control trial would be a better option. But because it was a community-based study, so cluster randomized trial was the better choice. Here in the image we have demonstrated. The image is taken from biostats.com with permission to use. And we have demonstrated that for community study, cluster randomized trial is a preferred choice. And for individual studies, a randomized control trial is better. Now, participant and ethical consideration. In this study, all the participants give oral informed consent. Now, we have to highlight here that according to Indian Council of Medical Research, verbal or oral consent should only be taken in exceptional circumstances. Otherwise, written informed consent should be taken, but this study did not employ that written informed consent. Additionally, the study did not mention how many participants were approached, how many individuals were excluded on the basis of exclusion criteria, and how many people refused to participate. Now, intervention. The study gave a comprehensive and descriptive outline of the intervention and the control group, and the possibility of measurement error and other biases arising due to data collection by principal investigator on such a large sample size were not acknowledged. By this, I mean they were collecting sputum samples, and how the sputum samples were collected. Were they collected in a sterile bottle or anywhere? It wasn't mentioned. So for that, we searched for the trial protocol in clinicaltrials.gov. I disclaim that this was not provided in the competition by the organizers, but we found the trial protocol, and they had not mentioned this for like the collection of method of collection of sputum. Now outcome, all biases in the measurement of outcomes were addresses properly. In the secondary outcome, authors have employed quantiferon gold plus IgRA, which called interferon gamma assay, to analyze the confirmation of tuberculosis in younger children. However, the use of IGRA in some countries, including India, is controversial. So this questions the reproducibility of the study in LMICs as well as India. Now, statistical analysis power was set to 90%, type 1 error was set to 5%, which is appropriate according to us. And all statistical tests were performed, and they were sufficient in convincing and answering the research question. Now coming to results, here is the most important part. Before collecting in the methodology, before collecting the sample, they made participant fill a questionnaire, and only 10% of the participant filled that written questionnaire. So what happened? We think that there may be a sampling bias in this, because only 10% of the participant who filled that written questionnaire. So there possibly a sampling bias can be there, because only literate people may fill that questionnaire, and illiterate people may hesitate to fill this questionnaire. And
you have 1 minute left.
Coming to validity of the study, despite the fact that cluster in the intervention and control groups were assigned using rigorous cluster randomization approach, the author did not remark on the variable that influenced the outcomes. For instance, tuberculosis is frequently associated with poor socioeconomic levels, and this wasn't assessed across the cases and control group. And here are the strengths and limitations of this study, and generalizability and conclusion. The outcome of the clinical trial is according to the current state of knowledge, and the principle of active case finding and management hypothesized by the authors in the country with high prevalence is plausible with the current scientific knowledge. This principle is even incorporated in India's National TB Elimination Program. These are my references. Thank you.
Judges, you can ask your questions now for 4 minutes.
So there are secondary outcome measures which you saw, like, is assessed by, this IGRA.
Yes, ma'am.
In among children born in 2012. What does that mean? And why that population was selected?
They actually had selected as a secondary outcome because in the 4th year of screening, what happened is they found in the primary outcome, they have found those prevalence of decreased in the intervention group by a statistically significant amount. So they also wanted to do that for children. So in the 4th year, they included this study. They included children in the study.
So that is acceptable. So your design is only changing. In 4th year, you're adding some other design. Is cluster randomized design gives you that type of option to change your design? So that is your ethical point, isn't it? That is a demerit in the study.
Yes, ma'am. And even it was not there in the protocol. They instantaneously took this decision after 3rd year of follow-up.
Okay. So another thing, like you said, IGRA is not very relevant in India. What does that mean? Where it is relevant, IGRA, and what it does detect?
IGRA actually detects interferon gamma release assay.
No, but what it detects? See, if it comes positive, what does it mean?
It is interferon gamma assay. It means that the tuberculous bacillus has the patient is having interferon gamma. Interferon gamma is it is a chemokine which is secreted by Th2 cells when Th1 cells and macrophages after in response to tuberculous bacilli.
That's
I don't
okay.
know that length of answer. No, I want to know, like, what does it mean? It means that the patient has latent tuberculosis, isn't it?
And in the NTEP, it is not IGRA is banned in India. It was as reference as given of National Tuberculosis Elimination Program. For India, we don't conduct IGRA in India.
No. That is why I want to know that. Why?
There may be many false positive results due to exposure. We have a lot of exposure of tuberculosis in India. This is actually more used in US and the developed countries.
Why do you say that? Why in US and not in India? Why national tuberculosis? That's madam's question.
Ma'am, there is a high exposure of tuberculosis in India. as a developing
So
country,
what? The patient will come positive. The patient will come positive, no? So what is the issue?
Yes, ma'am. False positive. False positive. Like because we already have a basal load.
See, countries where it is rare, their IGRA is very significant. Like for example, in US, IGRA comes positive. Patient is latent tuberculosis. He may had tuberculosis before and now he's cured, but he can be a risk to the population. And the IGRA test doesn't come positive immediately. It takes a lot of time, and it has a cost with it, and so it is unaffordable in Indian population. So we have this other tests, skin tests, which are very relevant for our own population. We don't require IGRA at all, unless it is in clinical trial setting. We do IGRA. In many of our biological studies, we do IGRA because that is a significant test, which is recommended by FDA. So if it is a US-based study, we do in India also IGRA, but not in clinical practice. Smriti, you can ask questions. Huh?
Yeah. Yes. You said about cluster randomized control trial. What is the main advantage of such a study design? State some 4 major advantages.
This design is very suitable for a large population, and already they have used a subcommune as a cluster, which is already divided in Vietnam. They have used subcommunes of Vietnam as a cluster. So advantage, it includes it has disadvantage of high standard error, and it has advantage of ease, and all the population can be included in the trial. So there will no be a bias of randomization if selecting a particular house of the cluster, or entire cluster is selected.
And it can be used for homogeneous population. Because we are selecting a whole cluster in this method, so a lot more homogeneity is obtained.
Okay. Ma'am, we'll be moving on to the next presentation now. Team.
Cluster randomized trial.
Okay, it's also, the cost is also an important thing. It's much cheaper. Okay. Fine, it's okay. We can carry on.
And and group A, here verbal consent is justified. In the community studies, verbal consent is justified. It doesn't require a written consent. See, again, there are norms for oral consent. So this is one of the studies where oral consent is acceptable.
Okay, ma'am. Thank you, ma'am.
Team B, you can stop screen sharing. Hello.
Hello.
Yeah. Minutes to complete your presentation. Your time will start once you start screen sharing.
Can I make sure that my part
after that session in which both of you can answer?
Hi, can I just make sure my participant, my teammate is inside because she had lost connection before.
I can see 2 team Cs. If you have a stable enough connection, please switch on your video.
Hello. Hello.
Yeah, we
Am I
can hear
audible?
you. You can go ahead. Yeah.
Hello. Hello.
You're audible.
You can go ahead. You can see your screen as well.
Am I audible?
Yeah.
Yes, you can go ahead.
Okay.
Yeah.
Okay, good evening, everyone. I am Vrinda Pahuja, and I'm here representing Team C. I am presenting a critical appraisal on the study of effect of aspirin on cardiovascular events and bleeding in healthy elderly. And this was done using CAF checklist. Next. Okay, so according to the checklist, we first start with the basic study design. So was the study design having a clearly focused research question? Yes. All the PICO questions were answered adequately. Was the assignment of the participants to interventions randomized? The interventions were randomized, however, they have not mentioned how the randomization was done. And was the randomization to effect bias according to the data presented by them? Yes. And was the allocation of the sequence concealed from the investigators? Yes. Were all participants who entered the study accounted for at its conclusion? Yes, but we have seen that there is an attrition by the end of the study. Was the study methodology sound? Yes, it was sound. They
Hi.
I lost connection in the middle. I'm sorry. Can I continue? Hello.
Yes, yes, you can continue, please.
Hello.
Can you hear me? You can continue.
Okay, so were the participants blind? Yes, the investigators were blind as well. However, it was not a triple blinded study, and the randomized control, yes. However, socioeconomic status have not been mentioned. All the other characteristics were clearly set out. Next. Okay, so apart from the experimental intervention, did the study group receive the same level of care? Yes. And it was a double-blinded study, so both the groups received the same care, irrespective of the group they belong to. Were the effects of the intervention reported comprehensively? The power calculation has not been shown. However, the outcomes measured have been clearly specified. They followed the Cox proportional hazard model, but the p-values have not been reported for all the results. Was the precision of the estimate of the intervention of the treatment effect reported? Yes. Do the benefits of the experimental intervention outweigh the harm and the costs? No, not according to the results that have been shown. Next. Hello.
Yes, we can hear you.
Yeah, okay. So highlighting the limitations in the study, they have specified secondary endpoints as hemorrhagic and cardiovascular events, but these are only events during the entirety of the duration. They have not conducted any interventions which are not leading to some events. So that is one limitation. Next. Hello.
Yeah, can she answer? I have her on call, so can she answer through my mic?
Yeah, you're audible. You can continue.
Ma'am, can she answer through my mic? I have her on call. Is that
Yeah, no problem. Yeah.
Okay, Brinda, ऐसे answer करो.
क्या?
Can you see the PPT? We are on the limitations of 100 milligram enteric-coated aspirin. So continue with the explanation. Continue with the explanation after that. I have you on call.
Okay. Was the limitations audible? Can't see.
Could you present for your team member? Because I think she's having a lot of issues.
Just a second.
If possible, if you have prepared as well, you could present. You will have 2 minutes left.
Just a second. Can you just hold on the time? I have not prepared for the presentation. Just hold on a second.
Okay, hold you.
Am I audible?
Yes, yes.
Matlab, I use your audio.
She's presenting through my phone, so can you just let me know if she's audible?
Yeah, let's you can try.
Hello.
Am I audible?
Was she audible?
Yes, yes. Continue.
Okay, so moving on to the next limitation, they have used 100 milligrams of enteric-coated aspirin for all the subjects, irrespective of the weight of the subject. So, aspirin dosage needs to be maintained according to the weight. So, if a person is of higher weight category, they need a higher dosage of aspirin, which could account for a lower therapeutic advantage to them. Moving on to the next limitation. So they have mentioned that the trial centers were randomly audited and a data quality committee monitored for the completeness and accuracy. However, they have not mentioned how the data quality committee was created and who was in the committee. Next, they have mentioned that annual in-person visits were done and regular telephone calls were done. However, they have not mentioned the frequency of
Ma'am, could you mute yourself? I think the audio is echoing.
I think she's just speaking through my phone only.
Yeah, go ahead. It's not an issue from your end.
Is the audio clear?
Yes, it is. We are on the trial procedure slide.
Okay. So in the they have not mentioned how regular the telephone calls were, and annual in-person visits for the study, which is only 4.5 years long, is not adequate because it would lead to attrition, which is probably the cause of attrition in the study. Other than that, they tested adherence to the trial intervention annually by the number of bottles that were returned, which is again not a very highly accurate way of testing whether there was an adherence or not. Then next is intention to treat analysis. Now, intention to treat analysis is done to eliminate the bias of there is an attrition due to one particular reason. However, in the next slide, we can see that the attrition was equal in both the groups. So I feel per protocol analysis would have been a better analysis to go with here. And the median follow-up was only 4.7 years, and which is a very short duration to actually check the accuracy of a drug like aspirin. Next slide. The confidence intervals were not adjusted for multiple comparison. The p-values are not presented for secondary and non-specified endpoints, which is another big limitation for the study. Next. Many millions of relatively healthy older persons in the United States have been taking low-dose aspirin is what the study claims. However, they have not provided any references for this claim. Other two limitations were they have not provided a sample size calculation and the randomization procedure has not been mentioned.
Guys, wrap up in 30 seconds.
30 seconds.
Okay, so next coming to can the results be applied to the local population? It can't be applied to Indian scenario because there is a lot of racial and behavioral dissimilarities, and the p-values of the subgroups would have been better if they were reported.
Other than that, attrition is another thing which is a limitation. The strengths were that the distribution of the participants was representative of the population. They were a well-defined outcome measures, randomized double-blind study stratification and matching was done, and it was clearly approved at all the centers, and the authors highlight the limitation of the attrition. So although the study did not include any participants from India, it did conclude that they did not contribute to any significant difference in the outcome. The authors mentioned that the reduced benefit of the aspirin for cardiovascular diseases could be due to decreasing prevalence of the same in the USA and Australia, which is in contrast to the trends in India, which is rising. A different outcome could also be contributed to the different lifestyles followed by people in India. However, until a similar study is conducted in India, which assesses the benefit to risk ratio of aspirin for primary prevention of cardiovascular diseases, I would apply the results of the study to my healthcare system.
Okay, I think we can go ahead with the questions now. You have 4 minutes.
He has not many.
Can you join in back?
So how you define healthy elderly? How you define healthy elderly here?
The question is, how do you define healthy elderly population?
Okay, ma'am, actually, these people have set up a eligibility criteria and an exclusion criteria. So people who are having diabetes mellitus, dyslipidemia, and hypertension have been classified as people at risk of cardiovascular diseases, and others have been taken in people who are not having risk of cardiovascular diseases. Additionally, they have taken people who also divided people who are smokers, and they have been divided and stratified, and they have also taken people who have no history of cardiovascular disease in the past, and because this is particularly based on cardiovascular disease, that is how they have defined a healthy elderly.
The issue here is
they
it's a
have
drug aspirin.
not taken anyone with a blood pressure of more than 180 systolic blood pressure and 120 diastolic blood pressure.
No, but what they have done is they have said like they excluded people only with cardiovascular disease, dementia, and disability. But there are a lot of other vascular disorders which are very common in elderly, which they are not ruled out. And if you see the result section,
yes, ma'am, actually,
in the discussion,
yes,
they have
ma'am,
written, the trial did not directly address the question of whether healthy older people who have been taking aspirin for primary prevention should continue its use. So they're contradicting their own, hypothesis. So one way you are saying it is healthy, there is no concept as healthy elderly. Do you know there is a concept of elderly? Every elderly after 65 years, they will have one element or other. So how they ruled out that?
Yes.
So because if you see the risk benefit analysis,
so they have ruled out only on the. Yes, ma'am. Ma'am, they have ruled out health only in terms of cardiovascular diseases. And with the question of aspirin, from the study that they have done, they have only 11% of the population which is actually taking aspirin priorly. So in that particular population, the sample size is very low, which is why they have probably written the statement that they cannot comment on that. But in the conclusion, they have mentioned that they would not recommend it because the benefits are not outweighed by the risk. The risk is much higher as compared to benefits in people who have not been taken aspirin as such.
And then why this study is only done in US and Australia? And if you see, the majority of the population is Australian, and the recommendations are for
yes,
US.
Ma'am.
So what is
the
logic
analyzers? Ma'am, the analyzers and the funders of the study are from Australia, which is probably why they have done it. And the reason they probably went to US was to take a discrepancy in race, because Hispanics and Blacks have only been taken from US. There are no Hispanics and Blacks from Australia.
Any major ethical issue you see in this?
Yeah. So that is what I was coming to.
Okay.
What is the ethical issue when you take a specific population or race in a study?
Yes. What major ethical issue did you find in this because of this?
Maybe some aspect of racism could have been attributed to that.
Is it racism or is it cardiovascular risk is more in this race? So you have to give both logics. You can't only talk in.
Ma'am, actually, in the when they stratified the population on the basis of race, they did not find any significant difference between the two races.
That I agree, but what is the cardiovascular risk in in blacks and Hispanics versus Caucasians and Europeans or Australians?
I'm not sure, ma'am. Priyati, would you like to answer that?
Ma'am, as of right now, we don't have evidence as to which race is more. Like if there is evidence, we are not aware of it. But we just know that according to our study, all the stratification matching was done to avoid all confounding factors.
No, what we meant was, see, you might not be aware of that, but what we are saying is when you take a specific race, okay, what ethical issues might come up besides that racism part which you are saying? That's not what we are worried about. Anything else specific you would work as far as the study outcome, as far as the interpretation of the result goes. We are talking with that respect.
Probably, ma'am, the incidence or the prevalence of one particular disease might be more in one race.
No.
So exactly.
You had a question.
Okay. So what?
Okay.
So what we mean? Okay. So you're saying that. So what does the study? What aspects should you be looking at? Results.
Ethically speaking.
It's okay. Okay, fine. I think so. You guys are a little not understanding. It's fair enough. No problem. We should not be going about the same question for a longer period of time. It's okay.
Sir, I think you wanted to ask a question. You could go ahead with it now.
So as this study has not many confounding factors, is there a method post-study or is there a method of...
Sir, you're not audible.
Hello? Hello?
Hello?
You're audible now.
Audible now?
Yes, sir.
Yes, sir.
Yeah. So as the study has lot many confounding factors, do we have any method of analysis wherein we can control these confounding factors and limit the bias?
Yes, sir. So they have actually done that by stratification and matching. So there is no contribution of confounding.
Method of analysis I'm talking about. Do we have a method of analysis wherein can we comment on
while analyzing the studies?
Yeah.
So stratification is also done while doing an analysis.
No, that is not the answer which is expected. Anyways, I'm done with the question.
Thank you, sir.
Okay, so Team C can stop sharing their screen now, and we'll add Team D to the meeting now. Team C stay in the meeting itself.
Hello, Team D, can you hear me?
Yes, here. I can hear.
Okay, you will have 6 minutes to present. Your time will start once you start your screen sharing, after which it will be followed by 4 minutes of questioning by the judges. You can start your screen sharing now.
Okay. Is my screen visible?
Yeah, your screen is visible. You can go ahead.
Just a minute, please. I'll be starting in 3, 2, and 1. Good evening. So today we'll be presenting a critical appraisal on the article titled Macrolide and Non-Macrolide Resistance with Mass Azithromycin Distribution using the Critical Appraisal Skills Program or CAS checklist as our guideline. Now, first, we wanted to start by assessing whether the trial addressed a clear focused issue. So, in terms of whether the population was well defined, whether the intervention comparator groups were mentioned, and whether the outcomes were also specified. So, the study had a clearly defined population as all the children 1 to 59 months of age weighed at least 3.8 kilograms and belonged to communities or villages with a documented population of between 200 and 2,000. The intervention group, they received an oral suspension of azithromycin at the following timetables, which is 6 months, given twice yearly for a period of 4 years. So the comparator group in comparison received a placebo suspension during the same time period. The outcomes of the study were also well defined in terms of the primary outcome being to measure the ratio of macrolide resistance determinants between the two groups at a time period of 48 months. And the secondary outcomes were to measure the ratio of the same at a time period of 36 months, as well as the ratio of resistance against non-macrolide class drugs at both 36 and 48 months. Then we wanted to assess whether the assignment of patients to treatments was randomized. So we found that the study was a cluster randomized and placebo-controlled trial, wherein 30 communities were randomly selected from a larger pool, and they were randomly assigned in a 1:1 ratio between the two groups. The randomization was performed at a community level, and the sequence for randomization was generated using a computerized software. The allocation was concealed by offering treatment to all the children in the community, and the intervention and placebo packages were separately labeled with 3 sets of random letters that were allocated to each group. Now coming to whether whether all the participants of the trial were accounted properly for at the conclusion, we found that out of 30 communities that were randomized, 15 divided in each group, we found that 29 of those were analyzed, and that one village withdrawn from the participation after 24 months time period, citing trial fatigue and internal issues. Then we found that the study was double-blinded, and the author stated that all field workers, trial coordinators, and investigators, except the biostatistician, were unaware of the link between the letters and the treatment assignments. So now we want to assess whether the groups were similar at the start of the trial or before the beginning of the trial. So we found that the authors had mentioned that at the baseline, the abundance of genetic resistance that was found for macrolides was found to be same in both the groups. And there was no significant difference in factors like age and sex between the two groups when measured at baseline. Also, the children from 3 to 59 months in all the communities had received seasonal malarial chemoprevention 8 months prior to start of sample collection. Now, we also asked whether, aside from the intervention, the groups were treated equally. So we found that the authors had obtained oral informed consent from the children's guardians before distribution of the placebo or azithromycin, and also before sample collection. Moreover, the frequency of distribution and monitoring visits were also kept same for both the groups. Plus, the sample collection and the processing was done in the same manner for both the groups, and the process of randomization and blinding was also done using similar methods. Now we asked how large was the treatment effect. So we found that in the results, at 48 months, the macrolide resistant determinants were 7.5 times as high in the intervention group than the placebo group, which, if you recall, is the primary outcome of the study. And at 36 months, the authors found that the resistant determinants were 7.4 times as high in the intervention group, which comes to the secondary outcome. Additionally, they found that there was an increase in antibiotic resistance among 4 other antibiotic classes, namely beta-lactams, aminoglycosides, trimethoprim, and metronidazole, and that this increase in macrolide resistant determinants, it persisted beyond 48 months, that is 6 months after the 8th cycle of distribution. So this is a photo from the article citing the results. Now, we wanted to assess how precise was the estimate of the treatment. For this, we chose to look at the confidence interval mentioned by the study. So the study had mentioned a 95% confidence interval, which was estimated by permutation, and this was not adjusted for multiple comparisons. And at 48 months, as we said in the results, the confidence intervals were 3.8 to 23.1. At 36 months, the authors had mentioned the confidence interval for 4 to 16.7. And these findings were actually consistent with the increase in macrolide-specific resistance that was detected after 4 distributions or at a 24-month time period at earlier points in the trial. And additionally, they found that adding 2 rounds of additional azithromycin distribution caused an increase in resistant determinants beta-lactam by 2.1 times, citing a confidence interval of 1.2 to 4. Then,
you have 1 minute left.
What are the factors that affected the generalizability and the external validity? The authors had clearly stated that the generalization of these findings to populations beyond rural settings, similar to those we studied in Aegeus, should be made with caution. These are the possible factors that we believe could influence the generalization of these results. And were all the clinical outcomes considered, were all the clinical outcomes considered, there was a likely confounding effect of anti-malarial chemoprevention, and the study also cites these following limitations. And these are the following benefits and risks are measured against each other, which have certain implications in the generalizability of the study. And therefore, we believe that the benefits were not worth the harms and costs of the study. Thank you so much.
Okay, we will proceed with the questions for 4 minutes.
So what you feel what was the baseline resistance of the population? See, that is very important to know, like, because initially they said, like, they were given this drug prophylactically for 2 years and they found that is by infection, but they are not very sure about resistance. But was there a resistant pattern already, established? Because the drugs are already given for 2 years. Now this is the only, the length of the duration is increased. So do you understand that from the study article? I mean,
Yes,
is that
so-
important? Is that important? And
Thank
why?
you for your question, ma'am. Thank you for your question, ma'am. So this study was actually kind of a continuation from the original model trial that was done to assess the risk of the child reduction in child mortality by mass azithromycin distribution. And there they actually found that azithromycin was indeed very effective. But one of the reasons that could be attributed to was that at that point of time, in the initial 2 years when they were testing this drug, there was a gradual accumulation of this antimicrobial resistance. And now when they're testing it in a specified population, that was one of the groups that was tested in the model trial, they actually found that, and they had also taken into consideration the baseline levels, which we don't have a specific value, it was not mentioned in the study map, but again, that becomes a very important factor to consider. Yeah.
So what is the scientific logic for using twice yearly azithromycin? Is there any regimen, which prescribes that? Because when you give erratic drugs like this, resistance is bound to happen. So what was the logic of giving twice yearly? Is there any logic?
Yeah, even I wanted to say that, in your appraisal itself, you're saying the risk versus benefit, the way towards risks. So how logical they were in conducting such a study? When before you actually start a study, you actually know what is going to happen.
Yes, ma'am. So thank you for your question. So the purpose of this study, what the authors wanted to highlight was the fact that the current systems of antimicrobial resistant surveillance are actually insufficient. And in their sample analysis, what they have done is they have preferred a metagenomic approach. So as compared to the conventional phenotypic approaches that are commonly used, so the authors actually suggested that the use of metagenomic approaches should be encouraged and should be combined along with the conventional phenotypic approaches to monitor resistance pattern in the community as a whole. Because just by using the phenotypic methods, you're not able to get a complete idea of what the resistance pattern in the community is, because as the study has shown that just by the distribution of the single drug, that is azithromycin, there is a development for broad antibiotic resistance just because of the mass distribution of single drug. And this also has many implications in the form that it could lead to propagation of macrolide resistance in untreated individuals, people who have not been exposed to azithromycin.
Okay, fair enough. Okay. Have they mentioned anything about the financial aspects of a metagenomic study? Have they included that aspect?
Ma'am, it is actually one of the limitations, ma'am, that these methods, number one, are they might be a bit costly. They're also a bit procedure. They're a bit intensive. They require proper storage, and because of one of the factors actually was that because they were preferring this metagenomic approach and they had to store the stool, they were not actually able to conduct the phenotypic assessment because they had to freeze it and then ship it to a different institute for analysis. So they could not get any mechanistic insights in the way that they could not look at organisms that could have been directly responsible for developing non-macrolide resistance. So they have acknowledged the limitation, and through development of technology and through accessible and affordable care, I think we can solve this limitation in the near future, maybe.
Is there any conflict of interest in this study? Because the study is funded with Melinda Gates and Foundation. Okay, and
Yes,
this is the US association, and it was actually that grant was for preventing blindness in some developing countries, and this was used for some other objectives. So, is there a conflict? Do you feel
no,
it is there or not there?
Thank you for your question, ma'am. So, ma'am, although the authors do not actually cite any conflict of interest, and we also believe that, ma'am, this trial was actually, like I was saying, the original was the model trial that was done to assess that how mass distribution of azithromycin in children reduce the mortality against trachoma infections, which can cause blindness. So this trial wanted to study the changes in gut resistome, or the changes in gut resistome in the community. How does it change with mass distribution? Is there any effect? And they did find that mass distribution has such and such implications, and there is scope for further research as well. So the authors actually did not declare any conflict of interest.
We have time for one more question. After that, we'll move on to the next round.
It's okay. I have no questions.
All countries are treated or being used as a labs or guinea pigs for such kind of studies. Little out of context, but I would love to hear an answer from this.
Thank you for your question, sir. Yes, one of the main reasons I think that third world countries are actually subject for all these studies is because of the high incidence and high burden of such conditions that are there. So because of the climate, because of the variation in socioeconomic status or the social situation that is there in third world countries, it's actually a breeding ground for so many kind of infections. And therefore, and because another reason, of course, citing the high population burden as well. So high population coupled with high disease burden, coupled with low socioeconomic status, coupled with we've always in a developing nation, we have certain lacunae in our public healthcare system. So these are actually a very good breeding ground for to teach us a subject. So although it might seem a bit like unethical, but I feel that such research is always for the betterment of society, and it also only furthers good research, and it's only to bring us out of that whatever darkness we're there. So this was my take.
See, if you want to do research in African countries, you have to give a right treatment so that patient actually benefits later. So when you're given an irrational treatment now in the initial days of childhood, later the children will not able to use any broad spectrum antibiotics, from penicillin to other drugs, which are actually very much required for all the infections, which is very common in Africa. So Pfizer donating the drug doesn't mean anything. So they are not doing any grandeur thing. They are getting a study out of it. But then there is a lot of implications on African population as such. So that is what we are saying. So there is a lot of utilization of a developing country data by a developed country to get into that hypothesis. You would not have used this hypothesis in the US population by giving 2 yearly azithromycin, isn't it? So you have to understand, would you use the same model for your population? If you can't use that model in your same population, then this can't be acceptable model.
Yes, true. That is why we've also believed that the benefits are not worth the harms it caused them. And when the question came of whether these results can be applied to the local population, we were favoring towards no. But then, because there were so many variables to consider, we wanted to put it in the can't tell category, because we felt that there are so many other resistance and also other ethical concerns that arise. So that's why the validity is not absolute in such a condition. That's what we also said.
Thank you very much. Thank you very much.
Thank you so much. Thank you.
Okay, so Team D can stop sharing their screen. And with that, we'll move on to the next round. Thank you, judges, for critically appraising these articles. And now we'll move on to the last round of the quiz, which is the clinician's choice round. Okay, so we'll move on to the clinician's choice round, and all the teams are ready. We'll start with the team F.
Yeah, just 1 second. The slide says the presentation will be rated out of 10 points. Will be 10 points.
Hello. What did you say?
I'm saying that it says that the slide says your presentation will be rated out of 10 points, but in the PDF that was sent, it says each judge will give score of out of 10 and final score will be sum of all scores, that is 30.
Yeah. Your presentation means whatever you say will be rated out of 10 points by each judge.
So 30 points, correct?
Yeah.
Just clarifying. Thank you.
Yeah. So shall we start if you are ready?
Yes, could you explain a format a bit more as to how the presentation before the first team? This is a very points heavy round.
This is actually, see, the question, a scenario will be given and the question will be asked. You will given a choice based on the scenario and you will have to choose the best option which you feel is correct, and you have to give the proper justification for that. On the basis of that, the judges will rate you, and they can also cross question you, and whatever you say there, that will also be rated.
So it says presentation. Do we have to make some documents?
No, it's not. Presentation means whatever you say.
Okay.
That's what.
And will there be a time limit for our justification?
No, there won't be a time limit for your justification. There would be a time limit for you to read the question and start answering, and that would be 2 minutes. Actually, that depends on the question. One of the length of the question. If the question is long, we'll give more time. Okay. So we'll start with the first question.
Can both the team members contribute to the answer?
The answer has to be given first of all by only one team member, and if there is any cross questioning, both the team members can contribute there.
Okay.
So this is the first question. So as you can see, a 1-year-old boy is brought to the emergency room by his parents because of inconsolable crying and diarrhea for the past 6 hours. As the physician is concerned about acute appendicitis, she consults the literature base. She finds a paper with a table that summarizes data regarding the diagnostic accuracy of multiple clinical findings for appendicitis. The table is given as follows, and based on the table, the absence of which clinical finding would most accurately rule out appendicitis in this patient. You would get 2 minutes to read and answer the question, and you would have to justify your answer. Okay, so your time starts now.
Yes, I can hear you. My point is that, spin and snout, so specific test rules in disease, sensitive test rules out disease.
What did you say?
Sorry, I was talking to my teammate. Sorry. Thank you for this question, judges. My answer is that fever would be the absence of fever would most accurately rule out appendicitis in this patient. My judgment is as follows. In a sensitive test rules out the disease, a specific test rules in the disease. This is a 1-year-old boy, and among children of that age, based on the table, fever has the highest value of sensitivity for that age. Therefore, this is the most sensitive test for that age, and therefore, absence of fever would most accurately rule out appendicitis. Therefore, so we can say that it would have the highest negative predictive value.
Okay, so we have created a probable solution for the answer also. I'll display that, and after that, the judges can either cross question or we can move on to the next participant. So the solution, probable solution, is as follows. Fever, as you said, is correct, and the justification which you gave was also correct because it has highest sensitivity under the age of 2 years child. So you can read this, and would the judges like to question over here?
No.
So you can go ahead. The answer was
Not
given
from my side.
Okay, so we'll move on to the next participant, and next team is Team A. Team A, are you ready?
So this was for which team? I missed it. That first
This was for
question
Team
was
F.
for which team?
This was for
Okay,
Team
thank
F.
you.
We'll move
Hi,
on to the
just
next.
a second. I'm just calling my partner. We got disconnected over the call.
Yeah, sure. Tell me whenever you are ready.
Yeah. Okay. Boris, you there on the call? Yeah. Okay. He's calling me. Yeah, we are ready. Sorry for the delay.
No problem. So I'll display the question now. So this is the question. You are a second-year psychiatry resident posted at a primary health center and want to decrease substance use in the community. You went through the literature and found out the following interventions. Interventions were, three interventions were found out. They were A, B, and C. Their time required for training professionals for delivering the interventions, their effectiveness, and the duration of intervention is given in the table as follows. Along with that, the effectiveness of multi-therapy means if two therapies are administered together, the effectiveness of that is also given. So based on this data, what type of intervention would you prefer in this case? And effectiveness is in terms of people able to quit after intervention. And this was calculated from a multiple randomized control trial. So your time starts now. You have 30 seconds remaining. If you aren't able to answer, we'll pass the question.
No, we would like to answer it. Three things to notice. Firstly, this is a PHC, which means the manpower is already less. We cannot compromise other specialities, if psychiatry training is being given, other more infectious diseases or NCDs could not be ignored. Therefore, we think the test which has the least learning curve, or the test could be taught to the multiple people the fastest, should be considered. The second thing is that it should have less duration, because the test which has multiple sessions, which means it has a possibility of loss to follow up. Lastly, balancing out the effectiveness, we think that the multi-therapy of A plus C, which yields an effectiveness of 60%, would be justified to decrease the substance use in the community with a less amount of resources and with a high degree of success.
Okay, so thank you for your answer. Now we'll move on to our probable solution. So as you said, multi-therapy A plus C, according to us, this was the correct answer. And your justification was also nice. Would any of the judges like to question or put any point further?
So why you feel that in PSC other infectious diseases should be given priority versus substance abuse? For example, that PSC has lot of drug users. Then the priority changes, isn't it? Is the priority depends on the disease prevalence, or it is fixed, like for infections we have to give priority?
Ma'am, could I take some 30 seconds to think about the answer? Ma'am, I would like to answer here that the proportional mortality rate is the best indicator for the disease burden in the society. We think that substance abuse, although it's a chronic disease, has a comparatively less proportional mortality rate. We think infectious diseases are much more having higher proportional mortality rate. Therefore, would be greater justified to take care about it.
Yeah, thank you very much.
Thank you, ma'am.
So we'll move on to Team B. Team B, are you ready?
Yes, yes, we are ready.
Okay, so we'll move on to the question. So this is the question. I'll read it out to you. A 63-year-old HIV positive man comes to you. You are a physician for a routine health maintenance examination. 4 years ago, he was diagnosed with HIV and was started on combined antiretroviral therapy. He tells you that he has been having difficulty adhering to his medication regimen. He has been unemployed for the past couple of years and relies on unemployment benefits to cover the cost of daily living. His father died of lymphoma at the age of 60 years. You have recently read about the results of a study assessing various risk factors for developing diffuse large B-cell lymphoma, DLBCL, in HIV positive patients. Based on the given table, which factor would you should you look out the most for while assessing the risk for DLBCL in this patient? And also, what advice would you give to him? And also justify your answer. So with this, your time starts now.
Okay, for this scenario, we will look for CRT adherence because the relative risk for if a person has a high adherence with CART is 0.69 with the confidence interval of 0.62 to 0.87, which the confidence interval does not include 1, so it is statistically significant, which is supported by the p-value. And we will there is also one other variable is also significant, that the male, but for male the relative risk is 1.08 times that of female, with the confidence interval of 1.01 to 1.19 with a p-value of 0.02. So in our opinion, the CART adherence will be the most like we should look that at that factor the most, because it is more important.
Also, then what advice would you give to the patient?
We will encourage him to be compliant with his CART.
Okay, so we'll move on to the solution. So as you said, as you rightly said, that CRT adherence is the most high risk factor, and you give a nice justification. and we'll let the judges take over from here and see if do any of the judges have any questions to be asked to the participant.
Not from my end.
Is the cost consideration important here? Because one, he is unemployed. He had financial, dooming because of his father's death, and he has to adhere. Okay, you're talking about adherence, so that will lead to some costing, isn't it? So cost is not important in this issue. Do you want to comment on that?
Yeah, yes, ma'am. We are discussing just a bit, please. Okay, so cost factor which should be considered as correctly pointed out by ma'am, but we need to highlight that ART in India is freely available for those who need it at various centers, ART centers. So cost may not be the issue here. If he cannot afford that due to his unemployment status, then also he can get ART at a nearest government ART center. So this shouldn't be the issue, in my opinion.
Thank you very much.
Thank you so much, ma'am.
So we'll move on to the next question to Team C. Is Team C ready?
Yes, we are ready.
Okay, so we'll move on. So this is actually a long question, so we'll give you more time in it. We'll give you 3 minutes to discuss and then answer. So a hepatologist has learned about the survival benefit of a new drug X in hepatocellular carcinoma patients from a fellow physician. She is looking at a list of HCC patients on her hospital's hepatology consult service and trying to identify candidates who might derive more survival benefits from drug X as opposed to a regular drug A. Based on the information provided below, which of the following patients with hepatocellular carcinoma would be an appropriate treatment candidate and benefit the most from treatment with drug X in comparison to drug A? So here are two tables given. One is this, and this compares the hazard ratio of two drugs, and the next table compares the adverse events. So I'll keep the slide on this. Whenever you want me to move on to the next slide, do tell me. Okay, so your time starts now.
Can you please go to the next slide? Hello?
Sure. Just a second. One point to add in this adverse event chart, the graphs where the asterisk is shown, it shows that the data there is statistically significant, while on the other graphs, the data isn't statistically significant. You have 30 seconds remaining on the clock.
Can we please go to the previous table? Hello?
Yeah.
Next slide, please.
Would you like to answer the question now?
Yeah, I like to answer. Okay, so according to the previous slide, we have seen that a person who is non-serotic is not benefiting. Right? Can we go to the previous slide?
Your voice is cracking. Can you repeat the last sentence which you told?
Am I audible?
Yeah, you are audible.
Yeah, so a non-serotic patient is actually not benefiting from this because the confidence interval varies from 0.51 to 1.32. It is crossing one, so it's hello.
Team C, you weren't audible. Can you repeat again?
Am I audible now?
Yeah, you are audible now.
Yeah. So if we see in the graph, the table that has been given in the condition where the cirrhosis is not present, even not
Team C, you aren't audible. Can any other participant of your team answer?
The risk, the hazard ratio is going to be considered as cirrhosis of less than 0.1 in hazard is 0.61 and
Team C, you aren't audible. Can other team permit of answer?
Hi, actually, okay. So what she was trying to say is when we come to non-serotic patients, the confidence interval is exceeds 1. So it is not significant. Hence, we'll go for a patient who has cirrhosis. Hello, am I audible?
Yeah, you continue. You can continue.
Okay. And
She's audible, but I don't understand what she's saying.
Can we type in our answer? Is that okay?
Yes. Yes.
Okay, thank you.
Meanwhile, can we move on to the next team, please?
Can they type the answer? To answer, isn't it? They have to type the answer. Team C, can you type the answer, please?
Hello?
Yeah, you are audible.
Yeah, continue, please. Can you answer? Team C, please answer.
Team C, your time is over actually, so you need to answer.
Yeah, can we just type in the answer? She's actually getting logged out again and again. I'll type in the answers. Just can we move on to the next participant and then come back to us?
Actually, that would reveal the answer in the PPT. So
we can give our answer and we can provide the explanation in the text.
You can give the answer first.
Yeah, you have to give the answer first. So
Like
once you give the answer,
we would like to go for option D.
okay. And would you like to give some justification to that?
Can we type that?
Yeah, you can type that.
Available.
So in the meanwhile, should we move on to the
It,
next?
it can't be like मैं एग्जाम को चला गया यार मेरे पास पेन नहीं है मेरे को पेन ला के दे दो. No, I
You
don't
can,
think.
yeah, just 20
you
seconds can be answered.
Yeah, you can't go ahead because that explanation they can later, look into it. They have to answer it, and then only we can go ahead.
15 seconds is enough to type.
See, initially the answer was given as B. Now she's telling D.
No, ma'am, the answer is D only. We've been going with D. We mentioned that cirrhosis, we will go with a patient who has cirrhosis first, because in the absence of cirrhosis, the confidence interval is more than 1, which is not significant. And we would also go, since my teammate is writing, the hazard ratio is exceeding 1 in the absence. Then we would go with a patient who has hepatitis B or C, because in those it is not significant. Moving on to the next slide. Can we move on? Here, there is no effect of anorexia. The effect of anorexia is not significant. Hence, we would go with a patient who already has poor appetite.
So do you finish your answer now?
Nephrotoxicity and infectious diseases are statistically significant. Hence, we can't go with a patient who is already on immunosuppressive therapy and has kidney stones.
Okay.
That's okay. I think so. We've got the answer and the justification also. We cannot keep on negativity. Okay, okay. Okay.
Yeah, we'll move on to the solution. So as you said, the answer was correct. A patient with severe cirrhosis and history of hepatitis C and poor appetite. So with that, would any of the judges like to question?
No, carry on.
Okay, so we'll move on to the next participant, Team D. Team D, okay. So you are a doctor posted in a primary health center in rural Bihar, and a patient presents in the OPD with chest pain, greenish sputum, shortness of breath. You suspect the disease to be aspiration pneumonia and are provided with 2 options for its screening, which are CT scan and X-ray. The cause, sensitivity, and specificity values are mentioned below. Choose the most feasible option for the screening and justify your choice. Your time starts now.
So we'd like to answer. Hello?
Yeah, you can carry on.
So, first of all, our answer would be that we would prefer an X-ray over a CT scan. The reasons for our choice is number one, first we would acknowledge that because now we are we have two options for screening. So even though the criteria for screening is that you should have a high sensitivity, and CT scan has a higher sensitivity of 85% as compared to 82% of X-ray. But we also see that the cost of a CT scan is 3,000 and the cost of an X-ray is nearly 200 rupees. And we must also consider the setting where posted in, that is a primary healthcare center, and it's in a rural area. And also the patient is presenting with high suspicion of aspiration pneumonia. So even though CT would see is a much sensitive diagnosis, but we would definitely prefer an X-ray owing to the economical aspects and socioeconomic background of the patient taking into consideration. And if feasible, we would also like to shift the patient to a tertiary healthcare center for referral if the need arises. And we would also perform all the necessary investigations if necessary, or whatever we can at the primary healthcare center. And at the tertiary, we would recommend a CT scan if if the patient can afford it. But our answer would be we would choose an X-ray.
Okay, so we'll move on to the solution. Yeah. So the answer and the justification you gave was correct according to us. Would any of the judges like to question the participant?
What you're suspecting as a diagnosis, even after doing X-ray?
Ma'am, assessing according to the clinical symptoms such as sputum, shortness of breath, it's most probably pneumonia, which has a pseudomonas in origin, because of pseudomonas, bacterial origin pneumonia.
Okay, by greedy sputum, you're directly coming to a diagnosis of pseudomonas without doing any bacteriological diagnosis.
Ma'am, we'll definitely go for a sputum culture, and we'll do for a culture sensitivity. Then we'll go for a probable diagnosis.
Yeah, sure. Yeah, thank you.
Thank you.
Okay, so we'll move on to the next question. Team E, are you ready?
Yes.
Okay. So this is the question. A patient presented to your OPD with chest pain, coughing, malaise, and wheezing. Based on these clinical features and X-ray findings, you arrive at the diagnosis of acute bronchitis. You have a choice of 5 drugs for the treatment of this disease, and the efficiency of each drug in curing the disease, which was found from analysis of various studies, is plotted below in the form of odds ratio. The graph has been plotted at the 95% confidence interval. Along with that, the pricing of the drugs is also given. So based on this, what would be the most effective drug of choice for you, and justify your choice? Your time starts now. You have got 2 minutes.
Hello. So our answer for this would be drug 1. The reasoning is that, first of all, drug 5 is eliminated because it crosses the odds ratio equals 1, the null point. Drug 3 is eliminated because it does not have any benefit. What we are left is with drugs 4, 2, and 1. Out of these, the median for drug 2 is highest. However, the cost is 2 to 2.5 times that of the other 2 drugs, drugs 4 and 1. So that is why, and plus the confidence interval range is also higher. So that is why amongst drugs 4 and 1, one has a higher median and a tighter confidence interval. That is why we would prefer drug 1 on the basis of exclusion of drug 5, 3, and then cost analysis and benefit analysis. Drug 1 is our answer.
Okay, thank you for your answer. And as we can see in the solution, the drug 1 is the drug of choice according to us, and the justification which you gave was also correct according to us. Would any of the judges like to question the participants here?
Is acute bronchitis a life-threatening event?
Okay, so we'll get back to you in 30 seconds.
Chronic bronchitis can become.
Hello, sir. So acute bronchitis, bronchitis is a chronic disease. It's fatal in very rare circumstances. Usually when death occurs, it is due to complications of the disease. So it is not acutely fatal in most cases.
So while considering the cost as well as the graph, we should also consider whether that drug is going to save a life. Thank you. So that is one more point while you decide upon a drug. Thank you.
Thank you.
You talked about cost benefit, but it is cost effectiveness. So when in the same group you do, outcome versus cost, that is cost effectiveness. In cost benefit, there are two, groups. But here it is only one group. You are actually analyzing the outcome in the same patient which you are giving drugs. Okay, the different drugs. So one group with outcome analysis always cost effectiveness. If you do a cost effectiveness in multiple groups as the drugs are given, then it is incremental cost effective analysis ratio (ICR). So that is not done here. So it is cost effectiveness, not cost benefit, which is spelled out by mistake, I suppose. Thank you.
Okay, so with that, we have officially actually ended the quiz, but we had questions, doubts on 2 questions as challenged by the participants. So we'll move on to that, those questions, and the judges would give the justification for the answer. Amit sir would give the answer, the justification for the answer, and I'll move on to the question.
Yeah, please go to the question first.
So this is the question as challenged by one of the participants. We would like Amit sir to justify the answer to this.
Yeah, the answer is case control study, and the justification for that is because it is the effect has already occurred, okay, and you already know the cause, okay. So there are some cases and there are going to be some controls out here. So the effect that squamous cell carcinoma has already occurred, okay, and you previously diagnosed with SLE and undergone a long-term prednisolone or methylprednisolone. So you hypothesize an association between long-term systemic steroid treatment and potential risk of squamous cell carcinoma. So even if the word is used risk, you can't every time use the word odds ratio at every time. Even if you are studying such kind of scenario, you cannot use what is the odds ratio each and every time. And even if you use odds ratio out here, while you will explain it statistically, you'll always say that if the odds ratio is say 2 times higher, so you always can say that the odds ratio or the risk amongst the cases was twice as the risk amongst controls. So because the basic case control study principle out here is because the cause and the effect, okay, are there already, and that's why it's a case control study.
Very respectfully, sir, thank you for that explanation. Just most suitable research design, we only chose cohort study because it allows us to explore association in greater detail, not just its most association, and within association, causal inference as well. Because these.
No. In a cohort study, what would you do here is you'll see the cases of SLE, or you'll see the case of SLE, and then you will give them systemic steroid, and then there'll be so there'll be a matched cohort. What you're talking about is a matched cohort, okay? But here the squamous cell carcinoma is already there, so it's not a, what you're talking about is a matched cohort, but here the effect is already occurred. Okay, so in that case, particularly as he is hypothesizing, okay, you have to also look at the hypothesis. Here is the null hypothesis already will be defined. Okay, she is already defined the null hypothesis that an association between long-term systemic and potential risk of squamous cell carcinoma. So here H0 will be, there will be no association. So when you want to prove that, and when you don't want to do a detailed analysis, she has made it very clear. She doesn't want a detailed analysis. She wants a very, very limited or very brief analysis wherein she is already hypothesized, and that's why the answer is case control style.
Thank you, sir.
Yeah. Can we move on to the next slide, please?
Should we move on to the sixth question, or does anyone have a doubt in that?
Does anybody, other teams also have a doubt on this?
Sir, just one general question. Sir, could it be ambispective cohort? Because if the exposure has occurred before, in that case, we could follow up the patient in an ambispective cohort.
Again, the most important or underlinable thing which is here is she has already hypothesized. Okay, and that's why it will go to in favor of case control study, and she wants to answer a single question. It is not going to be a detailed answer. It's going to be a single. And see, why do you want to do a case control study? Because it's in a resource limited setup, and you don't want to assess anything in detail. You want to answer a very specific question, and to answer a very specific question, this is something which you will have to understand. And plus, one more thing is. It is not a rare kind of a thing, so that's why case control looks a better. It's a rare kind of thing, and case control looks a better to me.
Thank you, sir.
Yeah.
Okay, so I hope all the doubts are cleared and there's no more further issues. We'll be coming back with the total scores in about 5 minutes. If you could please wait. If there is a tie, we'll be heading to the tiebreaker round, which is going to be the ethics round. In case not, then we'll be ending the quiz with the declaration of the winners.
Hi, we'll be discussing this question, right?
Yeah, we will be discussing about this.
You can go ahead and discuss.
Yeah, so the doubt which was taken up or which was raised by the concerned team was if it's a in vitro fertilization outcome, why it is not a longitudinal study. See, in longitudinal study, you have to follow up with the patient, not just for the outcome, but you are going to follow up in a longitudinal manner, like from day one, and you also are going to following up with other parameters also. And here, they are just going to see one-time assessment of PSS on all these scores. And later on, straight away, they're going to do the outcome. So any which ways, the endpoint is defined. It's not an open-ended endpoint wherein we have already seen one of the articles wherein there were quite a few endpoints, like 4-point MACE was there, and there are other endpoints. So here it's a endpoint is in vitro fertilization outcome. So that is defined, okay, and that's why you don't have to follow that up. And it's one time. What you can say is best way to do is take the data prior to starting IVF only one time. That's where it will clinch to case control study.
Hi, sir. Actually, I the doubt we had as the team was, even if we, since if we have to analyze the risk factor, the protective and the psychological factors with the association of the IVF outcome, and if we take the data prior to the IVF, how will we even start the association with the outcome? And if we just take it once, but how will we analyze the association then?
There are quite a few methods. You can do logistic regression, you can do chi-square, you can do, if at all the better outcome, good outcome, you can P, because there is PSS 10, so all these scores are there. You can, if at all the data is normally distributed, you can go for unpaired t-test. If it is not normally distributed, you can go for man-Whitney U-test. See, there are multiple methods, but ultimately you have to look at what exactly the scenario is. Somebody who's doing a fellowship, who has a limited time, right? So all these factors are also important while you're considering because if you're doing a fellowship, you have limited time. You have 6 months, so you have to finish within that stipulated 3 months. So I don't think it will be better to conduct a cohort study here. Okay. Yeah.
Sir, I agree the fact that it's a fellowship and it will not be beneficial for the time duration. But since the first statement mentions analysis of the outcome it is regardless of the outcome of whatever we do, because even if we do the factor analyzation first, it is the prevalence at that moment and not ahead.
I think you should hone up your concepts a little bit. See, being a judge, I have the authority, and I will conclude it here.
No, I'm not asking you to change the answer. I'm just asking you as a doubt.
No, so as a doubt, maybe we can conduct a session later on or something of that sort. But I don't think this is a platform where we can conclude with the doubts or maybe clarify the doubts. Okay. We shall conclude here. Yeah.
Thank you, sir, for clearing all the doubts. And I hope all the participants have understood what the point was of the study designs. We'll wait for Amit sir to give his scores, and we'll get to the total within 2 to 3 minutes. You could please be patient. You will no longer be required to keep your videos on. You can switch them off. Hello, can you guys hear me? I hope I'm
Yes, we
audible.
can.
Okay, so I'll be announcing the teams in the reverse order of their scores, starting from the lowest, so that we build anticipation. So we have at position number 6, Team C with 41 points. Then Team C is followed by Team E at 55.1 points. After this, we have at position 4, Team F at 58.7 points, followed by Team A with 59 points. We have a very close differential there. After this, for position number 2, we have Team D at 60.1. And the winner of Aegeus Quiz Confluence 2021 is Team B with 65 points. Congratulations to all the winners. Thank you for bearing with us throughout all the technical difficulties, and we welcome all the feedback that you might have. This was our first time conducting a research quiz, and we'll surely want to get better with time, and we hope to come back even bigger next year. Thank you, Smriti ma'am, Yashasvi Shetty ma'am, and Amit Bondwe sir for your cooperation throughout the whole event. We really appreciate you sticking with us till 11 o'clock in the night. And for all the participants, thank you for participating. And I would really love to hear your feedback once we are done. Thank you, everyone.